A hearty good morning to all. On behalf of Team SOGS, I welcome you all for the today's CME, Fertility and Reproductive Medicine. Fertility and reproductive medicine is a fast-moving field of medicine, and new treatment modalities are always welcome and implemented for better outcome. In this scenario, we aim to ponder over fertility-enhancing approaches in this CME. We have esteemed speakers with us today to guide us on this aspect. So let us begin with our first session. I invite the chairperson for today's session, Dr. Chandrakant Zadhav and Dr. Lalita Agrawal.
Dr. Chandrakant Zadhav, MS Dr. VMGMC Solapur. He is director at Sanjeevani Nursing Home Solapur, consultant at Yashodhara Super Speciality and assistant professor BJ Medical College, Pune. Dr. Lalita Agrawal, MBBS DGO, consultant obstetrician gynecologist at Guru Krupa Clinic, consultant obstetrician gynecologist at Saifi Hospital, and interest in high risk pregnancy. Over to you, chairpersons, to start the first session.
Thank you everyone. Thank you. First of all, thank you to organizing team giving me opportunity to chair the session. I would like to first invite Dr. Archana Shah Madam for this session on focusing on the infertility in preserving the fertility practice. Dr. Archana Shah Madam is a renowned IVF specialist from Solapur. She has done her diploma in reproductive medicine from Kiel University, Germany, fellowship in high-risk obstetric from Nashik University, working as an obstetric and gynecologist at Deep Super Speciality Hospital, working as a director fertility specialist at Solapur Infertility Clinic, Test Tube Baby Center, Solapur. Her special interest in infertility, embryology, adolescent health, high-risk obstetric. Madam is a very loving, caring, cooperative IVF specialist person. Over to me, madam. Thank you.
Thank you for those kind words. Good morning, everyone. First of all, I would like to thank Solapur Society for giving me this opportunity. On this Sunday morning, I am the opening batsman with this difficult topic of thin endometrium, which is still a mystery. So to begin with, the endometrium is the innermost mucosal lining of the uterus. It has a complex working pattern which responds and changes according to the cyclical changes of hormones, estrogen and progesterone, which are present in the female body. Endometrial thickness has been identified as a prognostic factor for success in assisted reproduction. Now, how to define this thin endometrium? Thin endometrium is a condition which is encountered by every infertility specialist very oftenly, and it is quite challenging and many times frustrating situation, not only for the consultant and for the patient also. What are the cutoffs of endometrial thickness? Many studies say that endometrial thickness less than 7 millimeter or 8 millimeter, then think of thin endometrium. But endometrial thickness less than 6 millimeter on the day of human chorionic gonadotropin administration considered as thin endometrium. Though pregnancies have been reported at 4 millimeter, 5 millimeter, it is apparent that at endometrial thickness less than 6 millimeter is associated with a trend towards lower probability of pregnancy. The incidence, if we consider all the ovarian stimulation cycle, the incidence is 38 to 66%, but in patients for IVF, it is 1 to 2.5%. Going back to the anatomy and physiology dates, if we have the anatomy of endometrium, we all know that endometrium is divided into upper two-thirds, that is functionalis layer of stratum compactum and stratum spongiosum, and lower one-third is basalis layer. This functionalis layer is important for implantation of blastocysts, and therefore it is the site for proliferation, secretion and degeneration. And the purpose of basalis is to provide regenerative endometrium following menstrual loss of functionalis. Endometrial cyclic morphological changes involve glands, stroma and blood vessels under the effect of pituitary and ovarian hormone. So this is the phases of menstrual cycle. From day 1 to day 5 in a normal menstrual cycle, it is the menstruation phase. Day 5 to day 15, proliferative phase. Day 15 to day 28, it's a secretory phase in normal 28-day cycle. Proliferative phase, it is the first phase which lasts from day 5 to day 15, and it is the stage where the endometrium may measure up to 11 millimeter. Secretory phase is basically the phase which has effect of progesterone stimulated by LH and lasts from 14 to 28 days of cycle. Maximum thickness achieved in this phase is 7 to 16 millimeter, and this is because of stromal edema and glands distended with mucus and glycogen. There is a coiling of small arteriole which is very important for proper implantation. Factors that influence the thickness of endometrium. We all know it's a major factor is serum estradiol level, then blood flow to the uterus and the endometrial tissue itself. So if there is previous injury, surgery or infection, definitely that affects the thickness of endometrium. Poor vascularity and low estradiol values lead to poor endometrial growth. The causes of thin endometrium. This is divided into iatrogenic, inflammatory, idiopathic and other causes. Iatrogenic causes. If the patient has history of DNC or myomectomy where the endometrial cavity is opened, or because of myomectomy there are intrauterine adhesions, or a history of caesarean section in which the cavity is curated to remove the placental bits, or history of polypectomy. It is difficult for the endometrium to grow again if the basalis layer is damaged during the course of surgical treatment. Inflammatory. In our country, tuberculosis of the endometrium is very important and common cause of thin endometrium, and most of the time there is irreversibly damaged endometrium. Apart from tuberculosis, other infections like chronic bacterial infections, sexually transmitted infections, pelvic inflammatory diseases can lead to permanent scarring of endometrium. Acute or chronic infection can lead to destruction of basal layer of the endometrium. If the healing takes by fibrosis, it leads to the destruction of endometrium and shrinkage of uterine cavity. Regeneration of endometrium even after complete treatment is very difficult as fibrosis destroys the basal layer. Idiopathic. All the time it is not necessary that the thin endometrium is due to any disease. It can result from individual uterine architecture or intrinsic property of the endometrium that affect its growth. Other causes like low estrogen levels. We all know the endometrium is estrogen dependent tissue, and if due to any reason estrogen stimulation is not sufficient, if there is improper follicular development, the endometrial layer will remain thin as seen in prepubertal girl, postmenopausal woman and in cases of hypogonadotropic hypogonadism. Then excessive use of clomiphene. Clomiphene is an ovulation induction drug with an anti-estrogenic effect on the endometrium. Repeated use of clomiphene can lead to estrogen receptor downregulation in the endometrium and persistently thin endometrium for a long duration. Same with prolonged use of progesterone and combined contraceptive pills that lead to thinning of the endometrial lining. Other systemic causes like hypertension, diabetes mellitus, asthma, depression, epilepsy, substance abuse like smoking are also responsible for thin endometrium. The factors like woman age, infertility etiology, drug protocol, estradiol levels, previous injury to the endometrium were supposed as important factors affecting endometrial growth. And woman age is an indirect factor on endometrium. Age affects more the ovary than endometrium. Inadequate blood flow. Uterine blood flow is an important factor controlling endometrial growth and is closely associated with vascular development of endometrium. Thin endometrium may be due to impaired angiogenesis and low uterine blood flow. Studies have shown that thin endometrium was characterized by high blood flow impedance in radial arteries, poor epithelial growth, decreased VEGF expression, and poor vascular development. Thus, the vicious cycle lead to thin endometrium that is related to impaired endometrial receptivity. They also suggested that high blood flow impedance of radial arteries at the start of menstrual cycle can be useful predictor of thin endometrium, although the cause of high blood flow impedance of radial arteries in patients with thin endometrium is not clear. The very important is how to measure the endometrial thickness. We all are doing this with transvaginal ultrasonography because of its advantage like it is non-invasiveness, repeatability, real-time monitoring and predictability. It is done with an empty bladder using transvaginal probe with high frequency, and the probe is very close to the endometrium. That results in better resolution, visualization but poor penetration. So how to measure? When we are measuring the endometrial thickness, that should be in the mid-sagittal plane. So one has to see the cervix as well as fundus at the same time, and the measurement is of the thickest echogenic area from one stratum basalis, that is the echogenic line at the interface of myometrium and endometrium, then to the middle echogenic line and to the other stratum basalis interface. The surrounding myometrial lucidity is not included in the measurement, and this measurement should be within 1 centimeter of the fundus. In up to 10% of cases, this image is difficult to obtain because of fibroids, adenomyosis, polyps, uterine orientation, body habitus and previous surgeries, patient intolerance. There are uterine contractions observed as waves of endometrium, and they can cause changes in the endometrial thickness up to 3 to 4 millimeter due to changes in myometrium and subendometrium. These are the different images or at different stages of menstrual cycle. In early menstrual cycle, the endometrium is thin, brightly echogenic strip comprising of basal layer. Minimal fluid can be seen in the endometrial cavity. At the time of ovulation or in the late proliferative phase, the endometrium is classical multi-layered endometrium with outer echogenic basal layer, middle hypoechoic functional layer and inner echogenic stripe at the central interface. And in secretory phase, it can grow up to 16 millimeter, becomes uniformly echogenic, isoechogenic with the outer basal layer, and this is because the endometrium is edematous in secretory phase. Now, like endometrial thickness, endometrial pattern is also important. Endometrial pattern should be multi-layered at the time of HCG trigger, and again this pattern is divided into grade A, grade B and grade C depending upon the echogenicity of the endometrium, and that is compared with the echogenicity of the myometrium. So a triple line appearance on the day of ovulation trigger is defined as grade A, and which is most receptive endometrium, and a homogeneous appearance which is more echogenic than the surrounding myometrium is grade C, and it is most of the time non-receptive. With the availability of 3D, 4D ultrasonography, additional factors can be measured. Those are endometrial volume, Doppler sonography of uterine and subendometrial blood flow, but endometrial thickness and pattern still remains the most research parameter for predictive value of IVF. Is there any score where we can predict the receptivity of the endometrium? So there is a score, uterine scoring system for reproduction, also known as Applebaum score, and this comprises the following parameters: endometrial thickness, endometrial layering, myometrial contraction seen as endometrial motion, myometrial echogenicity, uterine artery Doppler flow evaluation, endometrial blood flow, grayscale myometrial blood flow. And according to these parameters, there different score is given, and when we together calculate the score, this system says that when the score is 20, there is 100% chance of pregnancy. When score is 17 to 19, 77%, 14 to 16, 60%, and if the score is less than 13, very less chance of pregnancy. The endometrial receptivity, that is thickness and vascularity, is predeterminant in predicting the outcome of pregnancy is one. Uterine scoring system will help to perform embryo transfers in only favorable uteri and postpone or cancel those cycles in which poor uterine score is demonstrated. So we can change the embryo transfer cycle according to the score. Then after measuring the endometrial thickness, if you find the endometrium is defective, then further investigation or assessment is done by hysteroscopy. I am not going to talk in detail because we have a separate lecture on this, and sonohysterogram. This is performed in patients with thin endometrium. Endometrial sampling for to know about the endometritis, we do TB-PCR, gene expert or immunohistochemistry and sampling for endometrial microbiota. About the endometrial receptive array. This test is important to know about the receptivity of the endometrium. It is a customized microarray for genes involved in endometrial receptivity, and it is predictive of endometrial dating. ERA determines whether the sample is collected in the window of implantation and if the endometrium is receptive at that time. If the patient is receptive, that means her window of implantation falls on the day of the cycle during which the biopsy was performed, and therefore the blastocysts could implant on this day during the same kind of cycle. If in case there is changed window of implantation, a personalized ET can be performed. ERA test has shown high sensitivity, specificity for detecting gene expression profiles associated with receptivity. But these tests are invasive, expensive, cannot be repeated many times, and need highly intricate laboratory and trained personnel. There are no RCTs comparing clinical outcomes between patients with RIF undergoing ERA prior to their next embryo transfer and those not undergoing the procedure. This test can be used to confirm the receptivity of thin endometrium before planning FET, that is frozen embryo transfer. Whether this thin endometrium has effect on pregnancies and the infants. Multiple studies have shown that singleton pregnancy conceived using IVF is always at increased risk of obstetric and neonatal complications compared with spontaneously conceived pregnancies, though we don't know why it is so. The placenta is highly specialized temporary organ, is perhaps the most crucial element for good perinatal outcomes, and placentation is likely influenced by the underlying endometrium. There is one study by Mia et al. It was found that vascular endothelial growth factor was underexpressed in thin endometrium, leading to poor vascularization of the endometrium and impaired placentation. So, the thin endometrium, there are chances of increased risk of early pregnancy loss, hypertensive disorders of pregnancy, preterm delivery, chances of placenta previa, and more chances of more cesarean sections. Infants of these pregnancies, they are intrauterine growth retarded, small for gestational age, as well as low birth weights. Management of thin endometrium. Management of thin endometrium is divided mainly for cell proliferation, treatment for cell regeneration, and treatment to increase the blood flow. As endometrial thickness plays significant role in IVF outcomes, interventions for increasing endometrial thickness should be attempted when a thin endometrium is encountered. IUI cycle. We all are doing IUI cycle as first line of treatment in non-tubal infertility. During this cycle, the ovarian stimulation can be achieved by using clomiphene citrate, aromatase inhibitor, injectable gonadotropins. Estrogen produced by growing follicles induces endometrial proliferation, leading to increased thickness of endometrial stripe as measured by transvaginal sonography. Clomiphene citrate, we all know it's an estrogen receptor modulator, have anti-estrogenic activity at the level of endometrium, and because of this, endometrium, it affects the endometrium qualitatively as well as quantitatively. Several studies have demonstrated endometrial thickness is lower in CC stimulated cycles compared to natural cycle. The association between endometrial thickness and pregnancy outcome in gonadotropin stimulated IUI is not well studied. Studies have concluded that peak endometrial stripe thickness has a non-linear relationship with conception outcomes in gonadotropin stimulated cycles. Only in endometrial stripe thickness measurement is a poor predictor of outcome. Other than this, clinical pregnancy outcome is associated with patient and cycle factors like patient age, number of dominant follicles, and total motile sperm count. An isolated measurement of endometrial thickness has little predictive value and should not, therefore not be used as a sole indication for cycle cancellation or continuation. However, if we encounter with thin endometrium, we should consider endometrium pathology and investigate accordingly. In IVF cycles, for patients in whom the lining is less than 6 mm, investigate the causes and try to optimize the lining thickness before endometrium cycle, embryo transfer cycle. If in the stimulated IVF cycle, if we come across the thin endometrium, always counsel the patient regarding the negative effect of thin endometrium on the outcome and give them the option of freezing all the embryos and then preparing the endometrium and doing the frozen transfer. If we are preparing the endometrium with HRT and we see that the endometrium is not growing, the options are either you extend the course, increase the dose of estrogen, change the route. You can give oral, vaginal, transdermal or intramuscular estrogens, increase the duration of estrogen stimulation, or just induce the period and start with change in dose and route of administration of estrogen. This is very interesting treatment, that is use of prolonged estrogen treatment, which is not very well in research, but in this, the estradiol validated tablet in HRT cycle, it's not in HRT, it's prior to the embryo transfer, 15 to 18 milligram, this much high dose is given per day right from the second day of menstrual cycle, and serum E2 levels are measured. Serum, the aim is to maintain the serum E2 levels more than 600 and less than 5000 picogram. And if we find the E2 levels are less, then 2 to 4 milligram of vaginal estradiol valerate was added per day. And every 10 to 15 days the endometrial thickness is measured. And the ultimate goal is to achieve 8 millimeter endometrial thickness. And once we achieve 8 millimeter thickness, the cycle is, the withdrawal bleeding is induced with injectable progesterone, and the endometrium embryo transfer is done in the next cycle. So this the study has found that there is in 92% of the patient there is increased endometrial thickness, but further research is needed to support this. Granulocyte colony stimulating factors. It has been suggested that in women with persistent thin endometrium, GCSF treatment may improve IVF outcome. GCSF is a type of growth factor that stimulates bone marrow to produce certain types of white blood cells. In the endometrium, GCSF promotes regenerative activity of the cells and helps in increasing the blood supply. So this is cell-based therapy where we are achieving the cell regeneration. It is proposed that GCSF may increase IVF success by helping to improve implantation and facilitating continuation of the pregnancy. The route of administration, either intrauterine or subcutaneously. GCSF comes in the vial of 300 microgram per 1 ml. But more studies are needed to demonstrate its potential to improve endometrial thickness and pregnancy rate. There are two studies. The Glacier et al. In 2011 first published this paper with the successful use of endometrial perfusion with GCSF in 4 women with inadequate development of previously resistant to use of estrogen and vasodilators. Platelet-rich plasma. This platelet-rich plasma is defined as a volume of plasma that has a platelet count above baseline prepared by centrifugation of the patient's peripheral blood. We all know platelet contains granules that contains multiple proteins which has many growth factors, cytokines, interleukin-4, TNF-alpha and interferons. And these proteins are secreted in the event of injuries so that platelets are activated and then delivered to the site of injury or deficiency. Thus, PRP helps in cell proliferation, migration, tissue growth and healing, neoangiogenesis, inflammatory processes, chemotaxis and immune responses. Its advantage, it is a autologous biological material so that minimizes the risk of immune reactions and contagious diseases. PRP is considered less invasive since it is produced from the peripheral blood and preparation procedures are painless for the patient, affordable and convenient. Now how it is prepared? One has to have one good centrifuge machine and the tubes. So there are different techniques of preparation of PRP. The blood is withdrawn from the patient and it is centrifuged, and to get a 3-layer, the upper layer is of platelet poor plasma, then the middle one, the intermediate layer is of buffy coat with platelet concentrate, and the lower is layer of RBCs. And the middle layer is taken which is mixed with the supernatant plasma to make it a 0.5 to 1 ml, and it is injected inside the uterine cavity. About the endometrial scratch, it is mainly not to increase the thickness of the endometrium but to improve the receptivity of the endometrium. So how it improves the receptivity? There is it causes the wound repair process and thereby corrects the asynchrony between endometrial and embryo stages. Another possible reason for improved embryo implantation after endometrial scratch is production of immunological factors. The timing, it should be done 7 days prior to the onset of menstruation, immediately before the start of ovarian stimulation for IVF treatment with use of endometrial sample. Some IVF center combine this with the hysteroscopy. Stem cell therapy. This is still under research, but it is said that the transplantation of different stem cells with diverse source in the endometrial zone had effect on endometrium, such as declined the fibrotic area, elevated number of glands, stimulated angiogenesis and enhanced thickness of endometrium, better formed tissue construction, protected gestation and improved pregnancy rates. Thus, this stem cell therapy causes endometrial angiogenesis, proliferation and differentiation. Growth hormone. Growth hormone has been detected in the cytoplasm of proliferating uterine epithelium cells during mid and late luteal phases and in decidual tissue cells throughout pregnancy. In infertile women with poor endometrial development, additional growth hormone treatment is used to improve the endometrial thickness through uterine perfusion as well as the classical endometrial trilaminar pattern. Although mechanism of growth hormone effect on endometrium to improve the ET and uterine perfusion and IVF outcome still unclear. Human chorionic gonadotropin. This is, we know that HCG is the embryo endometrial relationship regulator and plays a critical role in initiation and maintenance of pregnancy. It modulates several endometrial paracrine parameters which correlate to endometrial differentiation, angiogenesis, tissue remodeling. But there are no systemic reviews. Intrauterine HCG, majority of recent published study, urinary HCG or recombinant is injected into the uterine cavity using insemination catheter after cervical mucus is wiped off with cotton swab or syringe. Papanicolaou et al. First published a report of use of human chorionic gonadotropin priming in follicular phase, where 150 international unit of HCG is given daily for 7 days starting from day 8 to 9 of estrogen therapy. Their rationale was HCG administration might have a positive effect on endometrial HCG and LH receptors. Their study suggested that apart from improvement in the endometrial thickness of approximately 20%, there may be improvement in the endometrial receptivity. Other drugs, these are used mainly to increase the endometrial blood flow. Pentoxifylline 800 mg per day, tocopherol 1000 mg per day, sildenafil 100 mg, either oral or vaginal tablet, L-arginine 6 gram, low dose aspirin 75 mg per day, but none of these therapies have met with much success. Individually, low dose aspirin that increases the uterine blood flow by increasing impedance to blood flow measured by declining pulsatility index of uterine arteries. Pentoxifylline, it is a potent antioxidant that affects blood vessels, increases VEGF expression, it is vasodilator, this decreases the local production of TNF factor, and combination of tocopherol and pentoxifylline has been reported to be useful in radiation-induced fibrosis. L-arginine, this is a nitrous oxide donor and which acts as a vasodilator. Then electroacupuncture, it is a traditional Chinese therapy which is used to increase the blood flow to the endometrium and decrease the resistance. Sildenafil citrate, it improves the uterine blood flow and leads to estrogen-induced proliferation of the endometrium. Can be applied to the patient with thin endometrium and it is effective for improving endometrial growth and pregnancy outcome. Thus, to summarize, thin endometrium in assisted reproduction is often defined as endometrial thickness less than 6 mm. The incidence in ovarian stimulation cycle is 38 to 66%. The incidence in IVF cycle is 1 to 2.5%. Transvaginal sonography is widely used investigation to measure endometrial thickness. The endometrium should be measured transvaginally in sagittal plane at the thickest portion near the fundus. Endometrial thickness as well as endometrial pattern is equally important to know the endometrial receptivity. Potential pathological causes of thin endometrium are Asherman syndrome, history of uterine surgery, infections, radiation, inherent architecture of the uterus, although the incidence of thin endometrium in this scenario is unclear. Thin endometrium may not impact pregnancy outcomes in ovarian stimulation treatment cycles. In ovarian stimulation treatment cycles, there is insufficient evidence to recommend changing stimulation medications or a specific stimulation medication or cancellation of cycle. In fresh IVF embryo transfer cycles, patients should be advised that endometrial thickness less than 8 mm may have negative effect on pregnancy and live birth rates. Fresh IVF embryo transfer cycle, patients with thin endometrium can be offered elective cryopreservation of embryos and transfers in subsequent cycle. For patients with history of thin endometrium in ART treatment, undergoing endometrial preparation for embryo transfer, there is insufficient evidence that any specific protocol, natural cycle or hormone replacement for endometrial preparation provides better pregnancy outcome. In patients with thin endometrium undergoing embryo transfer cycle, there is minimum evidence for the use of aspirin, tocopherol, L-arginine, intrauterine GCSF, pentoxifylline, sildenafil, HCG, growth hormone, platelet-rich plasma or stem cell to improve pregnancy rates. Although a thin endometrial lining is not the only factor influencing obstetric and neonatal outcomes in IVF, there is a large evidence that suggests that endometrial thickness plays a significant role. Interventions for increasing endometrial thickness with the belief of maximum IVF outcomes and minimizing obstetricals and neonatal complications should be attempted when a thin endometrium is encountered. Thank you for your patience.
Thank you, madam, for these elaborative and academic lectures. Thin endometrium is always a nightmare for IVF cycles. I said that it is very difficult to handle, but the take-home message is that the dilatation and curettage, we should not injure the basalis layers that may cause the thin endometrium. And as in India, we should not always remember the tuberculosis infections and the CC use, clomiphene citrate, always the patients comes to us with many cycles of CC already has taken. So that should be, we should. And in this thin endometrium, there is a very few things we can do. First is in IVF cycles, we freeze all. And then there is a mostly the PRP is the things that we
That
should
can be done.
determine. Okay, thank you, madam, for your elaborative and
Thank you.
such a talk. Any questions from audience?
In your experience, what can be the maximum dose of estrogen, regardless of the route of cause, per day that can be given, beyond which you think even if you increase the dose, the endometrium will not improve?
So far in my practice, I have not gone beyond 4 milligram QID. That is the maximum dose I have used, because after that, the endometrium is not supported well, and there are chances of intermittent shedding of the endometrium, even if you continue. But with this prolonged estrogen treatment, I think we can try that treatment in prior to the IVF cycles.
Thank you.
Madam, I also wanted to know, you just presented that paper, you just mentioned about that paper where estrogen was given for a prolonged period till endometrial thickness became 8. So what was the exact duration that was required to attain that
They have
thickness?
continued the treatment up to 3 months.
Up to 3
Every
months.
10 to 15 days,
They used
they
to
measured
evaluate the
the
thickness.
endometrium. The goal is 8 millimeter. But if they have not achieved the 8 millimeter, but 3 months, then they induce the progesterone periods with the progesterone.
But is it not that if we give estrogen for a prolonged period, it causes atrophy of the estrogenic receptors?
So endometrium is not well supported, and there is intermittent shedding, that what we many times face during the HRT cycles.
Yes.
But we can try this. I have not tried this.
Yeah, because it is said that if estrogen is given in a high dose for a very long period, it may cause atrophy
Yes.
of the estrogenic receptors, and instead of doing good, we may be doing harm. So we have to be very thoughtful when we are adding.
So this is the
estrogen
only
hormone.
paper what I
that is the
got,
only paper.
yes.
So I think we may have to try in some patients. Let's see. Thank you.
What is your experience in PRP for endometrial thickness, and how much you inject, and when do you inject it?
Quite often I'm using this PRP technique, mainly in the patients with thin endometrium, not thin as thin as 6 millimeter, but less than 8 millimeter. I try in the cycle prior to the embryo transfer cycle, just to know whether the endometrium is growing or not. 0.2 to 0.3 ml of the PRP sample is injected inside the cavity. Otherwise, there is backflow of the sample sometimes. If we give more volume, is injected inside the cavity. And endometrial thickness, that increases by 1 to 2 millimeter.
Any other questions?
Thank you, Archana Shah madam. The basic is, should keep the endometrial thickness 8 millimeter to have the better result. Thank you, Archana madam, once again.
Next speaker is Dr. Vaman Godke. He is from Sangli. Dr. Vaman Institute for Advanced Laparoscopic Surgeries and Research Training Centers, Sangli. He is a director of that centers. He has presented many papers in the state and national conferences. He has a basic interest, deeply interested in the laparoscopy. He has lectures on the laparoscopic reconstruction surgery, also role of laparoscopy in birth colpo suspensions in the stress urinary incontinence, laparoscopic myomectomy for difficult fibroids, and also he has given lectures very rare anomalies of tricornuate, tricholis, and bicolpus uterus. So please welcome Dr. Vaman Godke sir from Sangli.
Very good morning to all of you. Uh, Thank you, sir, for your kind introduction. And thank you, Virkar, sir, and Solapur BGY Society for inviting me today morning. So, sir has given a very difficult topic. Like, he told me to speak on fertility enhancing laparoscopic surgeries, but the hysteroscopy is the other side of coin. So unless and until we speak little bit about hysteroscopy, it is very difficult to speak on laparoscopy per se. So it is like a family without wife. So something like that. So hysteroscopy is nothing but the better half of laparoscopy. And so fertility enhancing surgeries, are they useful? So actually so many causes like tubal causes, endometrial causes, ovarian causes, then anomalies. So per se if you think almost 65% cases may benefit with the diagnostic as well as fertility enhancing operative hysterolaparoscopy. Per se, the laparoscopy and hysteroscopy not only diagnose but useful to treat the conditions also at the same time. So, diagnostic laparoscopy, where we can have an idea regarding the uterus, tubes, ovaries, POD, peritoneum, then the appendicular fossa, hepatic fossa to rule out few infections, and of course for the tubal patency as well. Hysteroscopy. Actually, hysteroscopy usually we used to put the scope into the endometrial cavity by dilating the cervical canal. Actually, hysteroscopy should start with vaginoscopy. First, with the introitus. Here, what ideas we can get is introitus, is it adequate, inadequate, even the nebotiensis, then infective foci, then the vaginal anomalies like transverse septum, vertical septum, like or longitudinal septum, then infections. So many conditions, even grade 3, grade 4 endometriosis can be diagnosed on vaginoscopy if the rectovaginal pouch is involved in that cases. Then the cervical canal, all 4 fornices, then cervical canal, we can go ahead with the cervical mucosa, mucous folds, transverse fold, longitudinal folds, then internal os. These are the folds. We know being today, we used to speak regarding the fertility enhancing surgeries, why God has given so many sperms if one is required. So this is internal os, then the endometrial cavity, ostium, and this is a good cavity. So in hysteroscopy evaluation of vaginal canal, at the same time when we go ahead we can have a cervical canal. So this is a beautiful mucosa, longitudinal folds, transverse folds, then secreting glands also you can demonstrate. So is it useful to see all these things? Yes, true. Because see, the millions of sperm deposited in the vaginal canal per se in fornices, so that is the first scrutiny for the sperms. How God is going to select the capacitated sperm. Then second is external os. Then they have to ascend into the endometrial cavity through the cervical mucosa, where this mucosa will provide the nourishment and ascend to the sperm into the endometrial cavity. And then these sperms are trapped into the transverse folds. They travel in the longitudinal folds. that's why we used to report the semen analysis as forward progressive motile sperms, and always we used to think regarding that count. So these are the primary folds, secondary folds, internal loss. If suppose a case of chronic cervicitis, what we can see as a diagnostic scopy in infertility. See here, these are the very few folds are there with fibrosis. Sometimes the hypertrophy of the cervical mucus secreting glands. Then the cervical canal polyp, fibroid, all these cases we may miss if we put the scope directly into the endometrial cavity. Then this is a cervical canal cyst. Then in IVF cases, when the procedure of embryo transfer, the difficult entry of cannula is again one more thing, where we can see this is the fibrocervical canal, king cervical canal. We can negotiate. How we can negotiate? If we do the hysteroscopy and report the IVF consultant regarding the tract canal, or you can diagrammatic representation if we give, then he may able to do the procedure with the smoothly. Then the endometrial cavity. In endometrial cavity, of course, septum, I think there is another lecture on hysteroscopy, so I don't want to go in details regarding this, which is one of the most common anomaly. All anomalies can be diagnosed 100% effectively with hysterolaparoscopy, but nowadays 3D ultrasound and all, 3D, 4D ultrasound gives us equally good results, but still hysterolaparoscopy gives the visual impression and 100% correct diagnosis. So in septum, like thin septum, thick septum, these are the incomplete septum. Then septum up to the internal os, up to the external os, then into the vagina, not up to the introitus, up to the introitus. So different varieties of septum. Even here we can diagnose it with vaginoscopy. Then septal resection, transection, excision. I think the another lecture on hysteroscopic surgeries, they will cover this. So I don't want to go in details of the septum resection, excision, upper and lower cavity septum and all. So septum again is a very easy procedure. Here only scissor is used. You can see the complete septum up to the external os, how it is excised, smoothly saved up from the endometrial cavity. Then Robert uterus is a variant of septate uterus where the septum is attached to the one of the side of the cavity like this. So the cavity will become like, on hysteroscopy only one ostium is visualized, another is not, because the septum is attached to the another wall like this. So this represents like a non-communicating horn, but it's portion of that normal cavity. So in Robert's uterus, like this is the single ostium, single tube is patent. Then we can resect this septum and communicate both the horns together. Then the bicornate uterus, again lack of fusion, this is a fusion anomaly. We used to diagnose on 3D ultrasound. The basic thing we all used to do the sonography is how you diagnose the septate uterus and bicornate uterus is, if we do freeze the image and pass the line between the ostium, interosteal line, and then line at the fundal level, if there is a depression, this depression is below the ostial line, then it's bicornate. If not, then it is septate. And how deep it is, depending upon that, it is a complete or partial bicornate uterus. So this is how the live image, and this is the sonographic diagrammatic image. So this is the partial bicornate and complete bicornate uteruses. Usually it does not cause that much problem, but recurrent pregnancy loss without any other fertility issues, one may think regarding the unification of the bicornate uterus or cavities, and that is nothing but the Strassman procedure. you might have been done open surgery. So this is nowadays we can do it endoscopically. This is the left horn, right horn, then vasopressin is injected, then the line of incision mark from one fundus towards the another, then Foley catheter put inside the each and these both cavities and inflated so that you can open the cavity nicely, and then after that remove one Foley, put one Foley in the cavity, and over which you can suture both the myometrium together, and this will become a single fundus. These are the two osteas and 3D image. So this is the 3D image. Then this is the term pregnancy almost. You can see the oblique line. This is because this horn is the larger horn, and at the time of cesarean section you can see this is the horn where the baby is, he has occupied this space, that's why it's oblique line, and this is the baby. So this is case of strabismus metaplasty. Then unicornate uterus, it is the least common, can be asymptomatic because capacity of horn is usually good. On ultrasound we can diagnose as this one side horn only one uterine angle is there, and you will know the banana sign and all on sonography. The recurrent pregnancy loss, one may think regarding metroplasty or widening of the endometrial cavity. Like this, the smaller cavity can be widened, and then one can support with the, how the Archana madam just now told us regarding the estrogen therapies and all, one can resonate the endometrium there. Then the non-functioning communicating horn, usually the non-functioning communicating horns should not supposed to resect, because if we resect this horn, then the uterus will deviate on another side and cervix will be diverted away from the seminal pole in the vagina, and that's why it is harmless, so one can leave it as it is. But if it is functioning horn, then what will happen? This menstruation will occur in the peritoneal cavity, and this menstruation as a normal menses, and that can lead to endometriosis and all. So in these cases one can resect this non-communicating horn. Sometimes you might have come across the ectopics in the non-communicating horns also. So this is an ectopic in non-communicating horn. Then the accessory cavitated uterine masses, this is the mass. How it differs from the robot uterus is, like robot uterus only single ostium we can visualize, but here we can have both the ostia, cavity normal, and in the myometrium there is an accessory cavitated uterine mass. One can go ahead and resect that mass, excise it and suture the myometrium well. Then unicornate uterus, didelphic uterus, usually it does not cause that much of problems with the fertility outcomes, but whenever the problems are there or recurrent miscarriages, one can go ahead and do the metroplasties. Then the hypoplastic uterus, these are the smaller uterus. So this is the arcuate uterus, hypoplastic uterus, and almost metroplasty we can do in these cases. Similarly, just now 6 months back one case delivered with us. She has secondary amenorrhea because of premature ovarian failure and hypoplastic uterus. We did metroplasty twice, then we gave them stem cell therapy so that the endometrium was not responsive. That's why we used stem cell therapy twice, and then we have a good endometrium around 6 millimeter, and we did donor IVF, and she delivered 6 months back. So the hypoplastic uteruses also can be converted into the fruitful outcomes with these advanced modalities. Then the fibroids. Regarding the myomas, those which are hampering the cavity or distorting the cavity should be removed, which may be of any size. So submucous myoma of any size, one can take it out, or the larger myomas which are more than 4 centimeter disturbing the endometrial cavity can be taken care of. So this is again anterior wall intramural large myoma. When we are tackling the myoma in particular infertile cases, what care one should take is all this tissue deposit with the uterus. This is the endometrium. So deposit everything back so that don't take out the endometrium or the tissue nearer to the endometrium. And again, this is a case of multiple fibroids with infertility, almost 4 fibroids. And we all know the basic principle of myomas, minimum incision, maximum myomas. Again, while enucleating the myoma, when we push all the tissue towards the myometrium, you can enucleate the myoma nicely, and the surgery will be bloodless, so that our struggle will be also less. So that is 1, 2. Then the third myoma. If we do dissect in correct planes, minimum blood loss, as such no blood loss. Then of course, suturing of the myoma bed is again a good thing. If we do the surgery bloodless, then the blood loss or blood collection in the myometrial bed is less, so that the scar adhesions or weakness of the scar, the chances are less. So the proper approximation and hemostasis is necessary, and of course the safety morcellation after the myomectomy. Then for submucous myomas of any size, smaller or larger, one can go ahead and resect the submucous myoma depending upon the surgeon's skills and settings, like in single setting, multiple setting, however it may be. Then the adenomyomas. Again, as the endometrium, how it creates a nightmare for the IVF consultant. Again, adenomyosis is one of the big problem, where the basic pathology we all know. In adenomyosis, how it affects these basically localized or focal and the diffuse adenomyosis. Adenomyosis may impair the fertility by affecting the uterotubal transport or altering the endometrial function or the endometrial receptivity. In severe adenomyosis, the endometrium won't come in a good way, or like a hazy A, B, C. Usually type C endometrium you can have in adenomyosis. Type A, type B we won't get. Then the endomyometrial junctional zone, you won't get it that clearly in adenomyosis. Whatever you want to do it, but at least the thickness we can manage, but these things we can't manage, like endomyometrial junctional zone and all. And of course, if you do the zone 3 vascularity, the resistance will be more in the adenomyosis, and that's why the endometrial receptivity will be poor. So we can manage those by medically and surgical. Surgical conservative management is adenomyomectomy. So just resect that adenomyoma and suture the myometrium well. Then even focal myomas which are deep or nearer to the endometrium, actually on ultrasound you may have a good uterus, but subendometrial cyst you might have been seen in some cases of IVF, and these are nothing but most likely these are the deeper adenomyosis, and you can do hysteroscopy in these cases. You can find the hemorrhagic spots like this. So one can go and resect with the resectoscope, so that the endometrium will be the cystic lesions, you can clear it off and you can have a responsive endometrium. Then after the vaginal canal, cervical canal, endometrial cavity will come to the tubal factors. Tubal factors, laparoscopy and hysteroscopy both gives us a tubal evaluation. The laparoscopy, we used to see all diagnostic cases, the tubal patency. Then this is the hysteroscopic tubal patency. If you are not doing laparoscopy, this dye is going through the ostium, that it indicates that tube is a patent tube. Then cases of tubal block, again These are the flimsy adhesions at the ostium. One can break the adhesions, cannulate the tube, and in the same way both the tubes are cannulated, bilateral tubal block case. Then the segmental infections, like this is the infective foci here, you can see this is the cause of tubal block. One can do segmental resection and tuboplasty in these cases. Then ischemica nodosa and infective pathologies like tuberculosis, PID and all. Then hydrosalpinx. Hydrosalpinx should be cleared before you are going for FAT. So, how hydrosalpinx will affect your implantation? So, this is a good video you can have. Here you can see how the fluid is draining inside the endometrial cavity, and that fluid will hamper with the implantation. That's why you can go ahead and resect the hydrosalpinx, and if it is more than 3 centimeter or loss of ciliary processes, one can go ahead and take out the tube. This is the hydrosalpinx which is complicating. Twist, it has undergone twist. Sometimes it may take ovary along with it. So, larger hydrosalpinxes one can treat it in time. So, these are the anomalies associated with the tube, like selective femoral agenesis, selective single site tubal agenesis, selective ovarian agenesis. These are the few anomalies associated with that. Again, this is a case where there is a lack of ovarian and infundobelly ligament. Both the ligaments are absent here. That's why the ovary has gone and stuck to the posterolateral aspect of the other side of the fundus. This is the left ovary, this is the right ovary, and this is the exophytic cyst from the right ovary. This is the right ovary which is firmly stuck to the myometrium here. So, this ovary is separated from the myometrium. Then we have prepared the uterovarian ligament from this local tissue, as well as from this smaller portion whatever we have here as a IP ligament we prepared, and then ovary is brought into that right ovarian fossa and sutured there. After that she delivered twice, and we did tubectomy also for this case. Then tuboplasty, of course, in tubectomized cases, there is the patency for the lateral end, then the patency for the medial end, and if you do good anastomosis, end-to-end anastomosis, you will have the same kind of patency after tuboplasty. Usually we used to do tubectomy to prevent the pregnancies, and once we revert it, they will have pregnancy. Then the ectopic pregnancies, this is the case of left side tubal twin ectopic. You can see this is the one sac and the another sac. We can milk out these ectopics. This is the one, and the another ectopic is coming out by the milking. So, these are the two ectopic sacs from the left tube, and tube is conserved. You can test the patency of the tube. That will give us idea regarding the tubal patency, as well as it will flush out the tube. Then if milking is not possible, at that time you can try for milking. If not possible, you can go ahead with salpingostomy. Just give a cut, remove all the contents, and let it be as it is. Then for ruptured cases, what we can do is, the ruptured segment you can resect, and that will convert into a segmental resection, or afterwards like a tubectomized case. Then you can go ahead with tuboplasty, it is useful. Then other ectopic pregnancies like ovarian pregnancy, cornual pregnancy, interstitial pregnancy, and the scar pregnancies. Then ovarian factors, actually polycystic ovary is a big topic to discuss and has to be discussed separately. Only thing I would like to suggest is never ever drill the ovary, any size ovary. 2 centimeter, 4 centimeter, 5 centimeter, 10 centimeter, severe polycystic, never ever drill the ovaries. Because the IVF consultant might have seen lots of cases of PCOS drilling, they are in failure, they have to go for donor oocyte. Those who are getting plenty of oocytes and we are in trouble to control the oocyte number, in these cases, if we are suggesting to go for donor it's a either end of that management, so never ever drill the ovary. So you have read in Love and Belly, like if surgeon is not doing PR, how they said the line in the same way. Here you can have a good line. Once you can drill the testis, but never drill the ovary. So next is ovarian and cysts. So cysts are of different varieties like simple cysts, complex cysts. In all types of cysts, what is the basic behind cystectomy is minimum incision. We are obstetrician, we are trained in delivering things. So deliver the cyst nicely and don't cauterize the ovary again here. Use minimum use of cautery. Usually I used to suggest the trainee people used to come while doing ovarian cystectomy, don't attach your cautery cable to the forceps. That's the best thing, because if you attach, you can press the paddle all the times. So don't attach it. Nature will take care of that. Then this is a ovarian cyst. I preferably choose on this case. This is a 6 months ANC, pain on and off, twist detwist phenomenon. The right ovarian cyst is a larger cyst. Why I chosen this? Because I want to show you without cautery we can do cystectomy for larger masses. Even this is a case of ANC, 6 months ANC case. So contents are clear. You just open it, suck all those contents nicely. Then put a scissor or mirror lens between the ovarian surface and the cyst wall. You will have a good plane. Then don't leave the plane. You just keep on pulling. And the cyst wall will come out nicely. So this is how the complete cyst wall has come out. This is the cyst wall, and if you see the ovary without any current, we have sutured it because being a larger cyst. So in vascular, in these cases the vascularity is maximum, even though in these cases we can do the cystectomy in that way. Now this is the case of twisted ovarian cyst. This is just demonstration how it twists and what happens. Here the exudates are there, ovary and tube had undergone twist. Just I have lifted it up, then automatically it has detwisted. You can see this is the avascular tissue. Just wait for a second, the blood is coming. Here the femoral end is bleeding. And once the blood flow comes, the tube can be conserved. So in the same way, she is again our colleague only with left side tubo-ovarian twist and gangrene. So few gangrenous changes are also there. Always try to preserve. Just whatever the gangrenous tissue which was taken out, and the ovary sutured nicely, and she come with the scan after a week with both the ovaries are normally in size, shape and ecotexture. This is a case of dermoid with a large posterior wall myoma. My question to you is, will you take out the dermoid first or myoma first? You answer me afterwards. So put the ovary inside the bag. This complete ovary is in the bag. Operate the cyst, enucleate the cyst inside the bag. So this is how the dermoid is coming out through one port. If you put the ovary inside the endobag and you try to separate the cyst, sometimes it may break, but it will break inside the bag only. Otherwise, this sticky material will irritate all throughout the surgery, and we can spoil the surgery. So this ovary dermoid first or other any surgery first, you can decide on that, but without spoiling, we can take out the dermoid also. So this 12-year girl, you can see here the uterus, how small. She have not attended the menarche also. And such a big dermoid, this is the scalp, and being gangrenous mass, we have to sacrifice that ovary. Then the parvovirus cyst. Parvovirus cyst is not a great pathology. It is very simple cyst. Sometimes it can rupture itself, or even you prick with the needle, it will drain out. What thing we have to keep in mind as a fertility enhancing surgery in cases of parvovirus cyst is the tube. You can see the tube. Tube will get stretched over the parvovirus cyst, like 10 centimeter tube will become 20 centimeter, and to save the tube along with its blood flow and patency is very important thing rather than the taking out the parvovirus cyst. So this is how the cyst is enucleated, but this is the tube, and we can have the patency and vascularity of the tube also. Then complicated parvovirus cyst. It can also get complicated. So this is the parvovirus cyst. This is the twist. Tight twists are there because of the parvovirus cyst. The altered color fluid. Here tube and ovary both are, these are gangrenous. See the tube, you can't shave the tube. When you hold the ovary, the portion will come along with your portion. This is the ovary. So sometimes this gangrenous changes is very difficult to conserve these things, and we have to sacrifice those. Then the endometriosis. I think we have a talk on endometriosis. It's being a big topic. I don't want to go in details of endometriosis. How endometriosis will start. These are the fire spots you can see. How this is at the ureter, the rectum, POD, flimsy adhesions, Khurd jelly sign. This is how the endometriosis will grown up with the adhesions. And so this is the basic pathology. Then problem is adhesions, adhesions and adhesions. Treatment is adhesiolasis, 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 and maintain the anatomy more towards the normal. Then the ovarian endometriomas, these are the different endometriomas, obliterating the POD, adhesions with the tube. In all cases of endometriosis, tubes are always patent. So tubes are not the problem, but problem with the ovary, and all the surgeons, they are trying to preserve the ovarian reserve. In endometriotic cases, everybody used to struggle to preserve the ovarian reserve by doing the cyst wall excision. This is the normal ovary, this is the plane of cleavage, then the cyst wall. One can peel out the cyst wall. Where we can't peel out is the hilum. Hilum is the one portion where the endometriotic cystic wall is firmly adherent with the ovary, where we have to leave the ovary with the cyst wall or cyst wall with the ovary. At that time, you can fulgurate that portion and take out the cyst wall. But is it really going to prevent the ovarian reserve? This is one of the histological study. So in this case, if you see this is the normal, the follicular density of the cortex and follicular density of the endometriotic ovary. So it has already reduced. So in these cases, even though we take care of ovary while doing endometriotic surgery, some kind of loss is going to happen. Then this is a ovary. What is it? This is the ovarian portion, fibrotic, dirty, white ovary. Ovary, when ovary we look laparoscopically, we should know how the ovary is. It is shiny, milky white color with smooth surface. All IVF consultants should know the normal ovary, because when an endoscopist gives ovary, ovary is normal and you will struggle for oocyte. That was the problem. Then what the basic behind this diagnostic technique of ovary is, see the surface, there is a no glistening, white or milky, it is dirty. So this is the only portion that is the fibrotic ovary, and all this is the exophytic cyst with the ovary. Then another ovary, you can see this ovary. If you measure on ultrasound, you will measure a good volume. These are the ovarian follicles, that is the exophytic cystic lesions, and one should differentiate these on ultrasound only. Then this is the fibrotic ovary. This is again a ovary with the exophytic cystic lesions, good size on scan, but these are the cystic foci occupied the complete ovary. What it might be? What is your diagnosis? This is a big problem in front of us, that is the premature ovarian failure. Nowadays we have even younger girls less than 20, we are going to have face this problem. Now this is the premature ovarian failure. If you see this case, you may appreciate the dates and name on the report, or don't, I don't know, but this is last week, 8 days back, this girl come to me. Now the age 17, LH 37, FHH 112, AMH 0.5 with secondary amenorrhea. So at the age of 17, if the premature ovary, she has to face this problem, and we have to face those problems in our day-to-day practice. It is being a difficult thing day by day, and cause we don't know. But the newer modalities we can think to treating all this is, Madam just elaborated the things like injecting the PRP or stem cells, intra-ovarian stem cells. Then again same thing with the endometrium, where the endometrium is poor, one can go ahead and scratch the endometrium, or even after that, if endometrium is not responsive, then we can go ahead and think regarding the PRP or autologous stem cell therapy. So this is how the stem cell preparation. Usually I never used to do the preparation. Stem cell consultant used to do the preparations for me, and this PRP and the autologous stem cell we used to inject in this way. This is the OHM pickup needle we use hysteroscopically, and at the basal zone we used to inject it. And this is our original research paper from my IVF lab of autologous stem cell therapy, which is published in the International Journal of FOSA. So now it's time to conclude. At laparoscopy and hysteroscopy helps us to diagnose and manage many conditions we have seen, from the introitus to the fornices to the cervix, cervical canal, endometrial cavity, ostium, tube, ovary and POD. So we can diagnose and treat all those conditions which improve the or induce the spontaneous pregnancy. Even it helps to enhance the ART results. Most of the times, see, you have posted the patient for diagnostic histolaparoscopy. There was nothing. Cavity is normal, tubes are patent, ovaries is good. We put that patient for diagnostic histolaparoscopy. She might have primary infertility, say, for 5 years. Then after few months, she will come with UPT positive. After diagnostic histolaparoscopy, simple thing, why patient used to conceive, we don't know. So what we think is, in layman's language, like how you take your vehicle to the servicing center, he'll give the wash and everything, and when we sit on that vehicle, how you feels, like that only the pelvic organs might have felt the things. It is like servicing of the genital system, and they get pregnant. So this is a miraculous thing. And again, don't blame that laparoscopic surgeon drill the ovaries. Don't ask the laparoscopic surgeon to drill it or take out the ovary or cauterize the ovary. So lab surgeons and the ART consultants should work hand in hand just to help our patients and to fulfill their dreams. So thank you so much, dear friends.
Thank you.
I used to charge 1,25,000 per case. Other centers might have been charging 8 lakh rupees per case, up to 8 lakh rupees. When we prepare the stem cells, actually they used to give you as per your demand, like 3 cc or 6 cc. We used to mix PRP and stem cells in endometrial cases. So 3 cc PRP, 3 cc stem cells, it's a 6 cc. We have a four walls or quadrant per se. So 1.5, 1.5, 1.5 you can inject at each and every place. And with this pickup needle, you are doing IVF cases. So this pickup needle, whatever the portion, like this serrated like portion, when you put it underneath the endometrium, it will go up to the basal zone because needle won't go like this, it will go like this. So you have to judge clinically, but if blindly, if you want to do it, just this serrated portion, you put it in the myometrium, it will be in basal zone. So in 4 quadrant, you can inject 1.5, 1.5, 1.5 cc. At that time, hysteroscopy, hysteromat pressure has to be constant. Why? Because when you prick, you are injecting 1.5 cc. When you take the needle immediately, it will come out. So instead of that, just you prick, you inject, wait. Wait for 2 to 3 minutes, then you take out the needle. You can see the whole of needle in the myometrium. It will close down slowly. Let it close. And then you inject on another side if you want to avoid the spill. Nowadays, the advanced stem cell injectable therapies has come up. They used to go through the femoral. They used to put the catheter to the uterine artery and at basal vessels they used to inject. But it is very difficult, but practice is going on. Studies will come, but at our level, we can do this.
So how much do you dilate the cervix? So what we use a hysteroscope usually is a 4.9 mm, 4 mm hysteroscope. So you will be putting the ovum pickup needle by the side of the 4 mm hysteroscope?
No.
Or through the operative hysteroscope
Operative
itself?
hysteroscope you can
Okay.
put.
Through the operative hysteroscope, we go up to the
It is
end
a bit danger if you put by the side, you can put it, but I don't think why people are hesitate to dilate the cervix. One can say like,
So
again,
just like how you put the scissors or anything, it's just like that you will
just
put the
like
ovum
that
pickup
only
needle
you
through
can
the
put it.
operative hysteroscope.
Always it should be, you can't see the needle, then you insert the hysteroscope and then you push the needle, you will see the needle in front of your hysteroscope.
Okay. So
That
just
will
like
be
any
the
other
safety.
operative procedure.
Any questions?
My question is pending, fibroid first or dermoid first? We will answer later on. Thank you so much.
Excellent presentation, Dr. Vaman.
Good morning, madam. Good
Nice
morning.
to see you here in Solapur. Just one thing that you mentioned about the one case where the fallopian tube probably a granulomatous lesion. So we do see still quite a few cases of genital tuberculosis. So my point to present is that such tubes we should not be operating on and should not be doing if you see the granuloma, do the resection and again do the anastomosis
See.
because they are vulnerable for ectopic pregnancies. It's quite common in that. So they have to be treated and then you do TB PCR and see whether it is there. And even if it is comes negative, I think with the appearance of the tube, you will come to know that whether they are affected by tuberculosis or chlamydia or whatever.
You are very true, madam. Thank you so much for your suggestion. The case I have shown, the mid-tubal block, the granulomatous tissue, she was not a case of tuberculosis. And the another case I shown regarding the tuberculosis, So many videos are there, particularly if I put one video, you might visualize how the tuberculosis is. That is an accidental diagnosis on diagnosticoscopy, where the caseating material used to pour inside the peritoneal cavity when we lift up. Then we stopped the laparoscopy there. We gave her AKT. Then she landed into ectopic after IVF. Then she come to me and I took out her tubes. So always never operate when there is an active pathology is the rule. So we never used to operate. That was the accidental finding during diagnostic histolaparoscopy. Thank you, ma'am. Thank you.
Thank you.
Thank you, sir.
How endometrial scratching is going to help, and endometrial scratching is done by a special instrument or by like curettas only?
Yes, sir. You are true. Per se, there is a controversy, scratching is useful or not. First thing, nothing is clear. These things are trial and error things. But scratching, if you scratch with the like curette, then it's a blunt. You may damage the basal layer also. Scratching with the scissors, you can scratch at a particular point. Of course, the basal layer can get damaged. That risk you have to take. But the thing behind is like it's a triple reaction. How the triple reaction come on the skin, in the same way we are injuring, we are creating the inflammation there. And that will increase the vascularity, and that may useful. But scratching, if you give a deep cut with the scissors and you do the second look surgery after few weeks, you might have seen the fibrosis at that places. So unless and until metroplasty is required, don't do metroplasties, because the laparoscopic surgeons, they used to do metroplasties in and out. But if you go and see the second look, endometrium won't grow most of the cases at that place. Sometimes it can undergo fibrosis, and that was again a problem, because that portion of endometrial will go off. So unless and until required, no scratching.
Any other questions? Thank you, Dr. Vaman Godke sir, for a nice lectures. I think that you are very good surgeons and also very good documenter also, because you have documented nice videos, and this is a very nice collections. I have firstly seen the hydrosalpinx videos, that is pouring the fluid in the endometrial cavity. As you have nicely seen that not only the laparoscopy, but the laparoscopy and histoscopy will make a complete family. And before going to the uterine cavity, we should inspect the vagina and the cervix also. Okay, thank you, sir.
Thank you so much. Thank you. And always it will be pleasure to be here in Solapur. Thank you so much.
There is little bit shuffle in the session. Now, next introduce Dr. Roshan Krishna Kumar. He has done her MS OBGY DNB FCPS DFP gold medalist, fellowship in gynec oncology GCRI Ahmedabad, fellowship in minimal access surgery ICOG Eva Women's Hospital, fellowship in advanced MIMS in endometriosis and cancer surgery, International School of Surgical Anatomy, Italy, training in OBGY oncology MD Anderson's Cancer Hospital, USA, Vattikatti fellow in robotic surgery AIMS Rishikesh, laparoscopic robotic gynec cancer surgeon, consultant gynecologist in JK Women's Hospital, Dombivli, Fortis Hospital, Mumbai, Apollo Hospital, Navi Mumbai. Over to you, sir.
So it's great to be here in Solapur. It's my first visit when Dr. Virkar called me. Many thanks to him and the Solapur Society for the invitation. So as Dr. Vaman started, ki laparoscopy is the husband, hysteroscopy is the wife. So like that, cancer is like the bahar wali. We want to keep her outside, but we can't avoid her. So we have to learn to manage both. So I thought of selected a unique topic, and sir agreed in the first go when I messaged him ki I'd like to speak on fertility sparing cancer surgery, because this is really upcoming. A lot of women are conceiving late. There are newer diagnostic modalities, newer things coming up. So this is a very important aspect from the infertility point of view, infertility specialist, gynec point of view, as well as the cancer point of view. Till now, cancer is mostly managed by surgical oncologists, and their approach is radical. You send them an ovary with the cyst, they will remove the ovary and send the patient back. So that's outdated. Newer techniques are coming up, newer publications are coming up. So I've just collected a few of the cases that we have done in the past 5 years since I have joined and started doing endoscopy. So to begin with, effectively treat cancer and preserving their fertility is the motto of fertility preserving cancer surgery. It's very important aspect of health. Any cancer of female fertility tract can impair. It's a life-changing decision whether to undergo. Like he said, it's a nightmare. Na? Thin endometrium is a nightmare for infertility specialists. So like that, cancer is a nightmare for everybody, for the doctor as well, because he has to first know that ye sab kar sakte hai, plus he has to convince the patient and the relatives who has to be ready to accept these treatments. Otherwise, the basic mentality is cancer hai, chalo, end of story, let's get everything done, let me save my life. That's most important. So it's increasingly being offered to women wishing to preserve fertility. It must have strong evidence, both on oncological as well as reproductive grounds, to recommend such surgery. And 15% of gynecological malignancies. This is a 2022 report published in JMIG, that 15% gynecological malignancies are actually being found in women in reproductive age. So we as gynecs are lucky. We have only 4 important structures: uterus, ovaries, vagina, and cervix. So coming to cervical, most common cancer, radical hysterectomy or radiotherapy has been the mainstay of treatment. Fertility preserving options include either a conization or trachelectomy. But believe me, fertility outcomes are very poor. Plus, it's very difficult to find cervical cancer at such early stage that you can treat or offer these options. Usually, they present with some hydronephrosis or already the parameter involved where you can't even operate. So as I said, only 9% chances of pregnancy are there, and pregnancy rates after NACT are better, but NACT is not a therapy for cervical cancer. Chemotherapy is not there. It's only radiotherapy because it's oncologically unsafe. So here I'm just presenting a patient whom we had started off that planning that we'll do a trachelectomy. So before we do trachelectomy is just removing the cervix, keeping the uterus and suturing back to the vagina, removing the cervix with the cancer. So we had started off, we always start off by doing the pelvic lymphadenectomy first, just to see whether the nodes are negative. Here you can see we started on the left iliac vessel, and if you all can notice this part, is the cursor coming? Yeah, this part, it's a bulky node. So we do all these cases with, this was done in 2018 end, I think. So that time we didn't have sentinel node mapping, so we used to do a full lymphadenectomy. It's such a bulky node. We subjected it to frozen section. You can see it's so big, it's even stretching beyond the vessels. So in such case, you know that it's not going to benefit the patient at all. So we had to take a decision. Patient was already counseled prior that she's going to undergo a radical hysterectomy if the lymph nodes are positive. Can you see the size? It's almost 2 centimeters big. So we went ahead, did a radical hysterectomy. We didn't do fertility preserving surgeries, but we preserved the ovaries because she was in her 30s. So what we did was keep the ovaries away from the radiation field. We fixed the ovaries to the lateral pelvic wall. Just make a small incision on the psoas muscle, on the peritoneum over the psoas muscle. Pull the ovary through there. Yeah, you can see it being pulled, and suture it there, both the sides, so that when the radiation oncologist is giving the radiotherapy, the ovaries are away from the field of the pelvis. So at least the ovarian functions are preserved if she ever wishes to go for oocyte freezing or surrogacy, it may help her. So we did this bilaterally. I'm going to go to the second side. This is the second side. I'll go ahead. So now comes to ovary. We all encounter as gynecologists, ovarian cysts are probably the most common things we all see in practice, be it infert, normal gynac, OBGY practice, everything. The problem with ovarian malignancies are they're aggressive, they have very high mortality rates, they are picked up very late. Standard treatment usually includes open hysterectomy, omentectomy, bilateral salpingo-oophorectomy, pelvic para-aortic lymphadenectomy, or either pre or post chemotherapy, which is the standard. So infertility options, what we can discuss in early stages is that preserve the contralateral ovary and uterus. Majority cases are that of epithelial ovarian cancer. Few may or may not require chemotherapy after surgery. So these are two cases I've combined. Both are young girls. One was 20, becoming a lawyer, and one was some 20, 22. They had huge ovarian cysts, almost 20 centimeters and above, and they were features of borderline cysts because of some increased vascularity in them. Tumor markers were normal. They were advised oophorectomy outside. They wanted to conserve the ovary under any circumstances. So we started off both, sorry for the name, I could not edit that part. So you can see these huge ovarian cysts. Now this is impossible to do laparoscopy. You cannot do cystectomy of these ovaries laparoscopically without spillage. So in the first case you see I put the Verey's needle directly into the cyst and started draining the cyst fluid to prevent spillage and then put the trocar. In the other video I'm collecting fluid for cytology and then I'll put it by inserting a trocar directly into the cyst and collecting the sample, preventing any spillage. Here you can see a trocar is being inserted into the cyst and it is being collected. Of course, support is needed so that no spillage is there. Then we do a small mini laparotomy incision on both cases. You can see the first one. Either you put a trocar and pull out the cyst at 10 millimeter suprapubic, or you give a small incision to 2.5, 3 centimeters and pull out the cyst. Do the cystectomy outside, because that will prevent and follow the oncological principles that will prevent exposure of the tissues anyway. Once you finish the cystectomy, you suture the ovary outside, put it back, check hemostasis, and both the patients, the first case you saw, she was done in 2021, follow-up is good. Now she's just finishing her studies. So this is a very interesting case. I think this video I'll have to play, it's not playing in the PowerPoint. She was a 34-year-old, married since 2 years, presented to her gynecologist with a USG of an ovarian tumor with solid components. She was, of course, she had not conceived yet. Her CA-125 was raised. MRI also suggested of a ovarian neoplasm, and she was completely counseled by a gynecologist that you have to undergo full staging surgery, you have no fertility potential, and then he sent her. So when she came, we evaluated, we spoke to her, we discussed that if it's early, there are no signs of spread, we can do laparoscopy, probably remove one ovary and try and preserve. So today she has twins delivered last year, conceived through ART on regular follow-up and no relapse yet in almost 3 years. Video kidhar gaya? One sec, I'll just, you are playing? Yeah. So he'll just play the video, because that video is too large and it's not playing in the PowerPoint. Enlarge kar dena. Yeah, so this was the laparoscopic picture. I know it will raise many eyebrows, are CA ovary mein lap kar diya, but we have started doing even for a little advanced disease following the oncological principles. Here you see, as Dr. Vaman said, we have put in a bag to prevent any rupture. We did an oophorectomy unilateral on one side. And without causing any spillage. Then the question comes, how do we remove such large masses? So what we did, I'll just take it back here. Either it is like the previous case, do a mini lap and remove them, or like in this case, we have introduced a 10 mm trocar through the POD, through the vagina, we pushed it, and we pulled the bag out through the vagina, and we actually removed the entire tumor in the bag through the POD. There you can see the pultaceous material coming out. It was not coming out in bigger chunks as well because it was all necrosed inside, preventing any exposure of tumor cells anywhere in the body. So moving ahead, we closed the POD. We always do these cases with frozen section. We took some peritoneal biopsies. Once the frozen section came as positive for epithelial ovarian cancer, we knew that what we had to do, so we went ahead and did a unilateral pelvic lymphadenectomy on that side. Here you can see the retroperitoneum being opened. I'll fast forward few insignificant steps. That's the obliterated hypogastric artery and the uterine artery, which my assistant is now grasping, slowly opening and developing the spaces for the pelvic lymph node. Now it's easy to do pelvic lymphadenectomy when the uterus is absent, but when the uterus is present, it's very difficult to maneuver in that little space. So we still went ahead and did the pelvic lymphadenectomy there. You can see the uterine artery, the paravesical and pararectal spaces very clearly now. Also, We finished the lymphadenectomy completely on that side. And then the next step was to do an omentectomy. So we went ahead and did an omentectomy also laparoscopically. Yeah, this is the completion of the lymphadenectomy procedure. So my focus is not on lymphadenectomy. This is the omentectomy part where we tilt the patient a little bit and start doing an omentectomy. This is also done in 2021, so that's why we are using harmonic. Now we have shifted to LigaSure for this purpose. After doing the omentectomy, we put it in the bag and remove it, and then you can see this is the complete picture. This is the patient whom I said has delivered last year, and she's on follow-up regularly. Luckily, she had not required chemotherapy post-surgery. So these approaches are possible only when you yourself also believe that these things can be possible. Band kar dena. Back to presentation. Yeah. Okay. So then endometrial cancer. Today it's increasing so much that we are seeing young people with so much PCOS, with lifestyle changes. It's gone up so high that it's diagnosed at very young ages. Now this fertility sparing approaches may involve hysteroscopic resections followed by high dose hormonal therapy. Complete remission is usually achieved with very high doses of therapy as well as very early stages of cancer, and pregnancy rates are good usually in this with the help of ART. So megestrol acetate is the drug of choice, can be given in very high doses from 80 to 600. Some studies say even up to 1600 mg per day can be used. Or you insert an LNG IUD, which is magic, followed by close monitoring with hysteroscopy and biopsy at regular intervals. So coming to this case, she was a 27-year-old with intermenstrual spotting. Now this is another nightmare. She's an IT professional, well educated, and she's unmarried. And she came with this intermenstrual spotting. She was put on all sort of hormonal therapies, OC pills, progesterone, but her spotting never reduced. On sonography, it was diagnosed as endometrial hyperplasia with polyp. She was counseled for hysteroscopy. Now here you can see the USG picture. Now when you see the hysteroscopy picture, you'll also realize the importance of vaginoscopy and not dilating the cervix at all. Here we knew that there's a polyp, we directly went in with a mini resectoscope. See, this mini resectoscope is only 15 French. So that also does not require dilatation of the cervix at all. You see, there's entire growth in the endocervical canal and the uterus is normal. So if you dilate this type of cervix, you're going to miss all the findings. You're not going to get anything because there's going to be blood and all the internal architecture is going to be damaged. You see, the uterus is absolutely normal, but the endocervical growth is showing vascularity, it is hypervascular. So we went ahead and resected all this. Can you see those tentacular-like appearance of those endometrial glands? That is classical of malignancy. So we did a resection of all that. Sorry. कहाँ चला गया? कहाँ गया? Yeah. आगे लेके आ जाओ. Yeah, we went ahead, did resection of the complete thing, gave it all for histopathology. It turned out to be well differentiated adenocarcinoma of the endocervical canal. So that's where hysteroscopy also plays a very important role. Now, she was very stern. She said that whatever comes, I don't want surgery, I don't want my uterus to be removed. With combined management with medical oncologists, she's been taking Meges, that is megestrol acetate, leupride depot for years now. And she has undergone multiple biopsies which have luckily been negative as of now. But she's aware that anytime she may require surgery, but still she's certain that she wants to wait till the time she gets pregnant. So that's why we are also going ahead with this. Now the last hysteroscopy, she went, just last year, early last year, she underwent an oocyte cryopreservation. She recently got married. Her biopsy in early 2023 was negative and is planning to undergo embryo transfer later in this month itself, and she has been in follow-up since the last 2 to 3 years, and regularly we keep doing a hysteroscopy on and off, sometimes outpatient endometrial biopsy. Then atypical hyperplasia we encounter so much. Now this is a case of a nurse. She was working in a government BMC hospital, corporation hospital for many years. Sorry, I typed the age wrong. She was 39. and she was trying to conceive for the past 10 years. She didn't. She was diagnosed with atypical hyperplasia in 2021 on hysteroscopy, and she was put an LNG device. After 3 months, the biopsy was reviewed. The hyperplasia had regressed. She was aware what she was going through, so she immediately went for IVF. She conceived, and last year, I mean, just this October or last August she delivered. This October her biopsy was showing again foci of endometrial cancer. Now this is her video of her atypical hyperplasia. It was just focal. Now again, vaginoscopically we have entered the cavity. You can see the uterus looks otherwise normal, but there's this foci again of hypervascular area with a polyp. So this was resected with scissors. Here also we could have used a resectoscope, but the base was small. That's why we used only scissors, and to prevent more harm to the endometrium. So once this was, oops, yeah, okay, so yeah, I think my friend there is taking control whenever I'm going wrong. That's very nice of him. Yeah, so once this was removed completely, it was taken out with the help of a grasper. This was the one that showed atypical hyperplasia. And then the next video, which showed only focal adenocarcinoma, we now have started since the past 1.5 to 2 years, we have moved completely to sentinel lymph node mapping, which is a very new technique. So this is how the ICG dye, that is the green dye which is injected, it shows on the camera. So we inject it on the cervix at 3 and 9 o'clock position. This is done for endometrial and cervical cancers now. So you inject it at 2 and 5 millimeters, 1 ml at 3 and 9 o'clock position. And then this is how it looks intraop. Is this playing? Yeah, I'll play it here. So this was her surgery. We have opened the retroperitoneum before even doing a hysterectomy. You can see the ureter there on that side. You just swipe lateral to the ureter. You start seeing the uterine artery, which will be just seen. You open all your spaces. Can you see the uterine artery is immediately there? And all this green portion is the first place where this dye has reached. That is the sentinel lymph node, is the first lymph node which drains that particular area. So if that is negative, that means the cancer has not yet started spreading. If that is positive, then it may have spread and we need to do a bigger lymphadenectomy, a complete lymphadenectomy, maybe even para-aortic. So you can see we go ahead and dissect only that green part over the vessels. This is a different mode which again confirms the high concentration of the dye there. So this is used with near infrared imaging. Now you see there's another mode which even turns the tissue orange. That indicates that there's more concentration of dye in that particular area and that part shouldn't be missed. So that was taken, that was biopsied, they were all negative, so further lymphadenectomy was not done, sentinel node biopsy on both sides was done, and then a hysterectomy was done. This case was just done in, I think, October 1st week. Yeah, so this is the final picture post her surgery. Okay, now one more thing which we can't forget is GTN. Now this is something which everybody is confused, nobody knows how to manage. So this was again a 27-year-old, married, she had a first trimester spontaneous abortion, she underwent a DNC. And after that for a month she was having persistent bleeding. The gynecologist there did a sonography, they found RPOC, and then she came to us and we were also confident, okay, RPOC dikh gaya hai, thoda vascularity hai, we'll do hysteroscopy and remove the RPOC. So when we went ahead and did her hysteroscopy, we could see a huge RPOC, almost 2 centimeters. Can you see how big that RPOC is? And it was invading the myometrium at many places. Now this type of RPOC cannot be removed with the ovum forceps also. Some part is going to be removed and DNC is never going to remove it. So hysteroscopy has helped us here. We again did resection with the resectoscope. In this case we used a bigger resectoscope because the os is usually open in cases of RPOC, and to prevent fluid leakage in with the miniature resectoscope. So while resecting, what we noted was we had started seeing the myometrium also. That deep the RPOC. Can you see the endometrium and that RPOC has been removed, but some of it is still going and is seen so close, invading the myometrium at those places. At that point we had a doubt that we could be dealing with something which is not normal. So we removed everything, sent it for histopathology, which is more or less normal. Histopath has not shown anything. But what we did was we did her beta HCG. You can see the myometrial fibers are being seen. That much we had to remove to get those all RPOCs out. Further, going ahead, we did her sonography. You can see the vascularity of her uterus. This is just of the right corner, but the entire uterus is so hypervascular. And you'll be shocked to know her beta HCG report after all this. In June, when we did it, her beta HCG was 10,000 and something. Then again, we thought, okay, now we have finished hysteroscopy. Let's wait for a month. Again, we did, it was the same. Then we just followed her up, thinking that now that the foci is out, it will slowly start following. Till around September, it dropped till 3,500. That's when we decided, okay, let's give methotrexate and see whether that's going to help. After some 3 doses of methotrexate, it finally came to 586. But then we repeated the level in 10 days and again it had gone up. So that means there was some persistent GTN still left. So such cases, you cannot remove the uterus. We have our medical oncologist on board with us. Now she is receiving extended methotrexate therapy. Means 1 week she'll receive alternate methotrexate, the other week she'll get off, again she'll receive methotrexate, and finally her beta HCG levels are showing some decline. So these are just the fertility potentials of few of the cancer. You can see cervix is the lowest, 15%, endometrium has a high fertility potential, 60.2, and ovary has a moderate, around 50%. So take home, initial conversation with the gynecologist is the most important. We as gynacs should know that these options are available, so we can, since we are the first contact, she is going to come with you only with the complaints or with the report for counseling, and you should know how to guide her. We cannot be in the olden zamana and say, okay, fine, let's go and remove everything. If she is desirous of fertility, we should be able to offer her this case, of course, if she is a suitable candidate. Further decision should be only done with a consultation with gynec oncologist. And of course, it's only available with certain cancers. With vagina and vulva, I don't think there's any fertility preserving approach. Conservation should be made before, conversations with the patient should be made before the start of treatment. Means she should know exactly what all can happen. On table, you cannot decide while doing the surgery, okay, abhi ye spread hai, now I'll remove the other ovary. You have not taken consent, patient doesn't know, relatives are unaware. So you have to counsel all of them right before, and it should be known that it's not always an option. Plus, it also depends on the patient's desire and will to achieve pregnancy. Our counseling, it should be told that there are chances of recurrence, change of plan, intra-op, if frozen section shows a different result, and accuracy of frozen section, plus need of resurgery should also be discussed, and involvement of gynec oncologists, other specialties, medical oncologists is a very much must. So with this, I'd end. I think it's a vast topic, but I've just tried to throw some light on this. So thank you very much for a patient hearing. Thank you.
Thank you, sir.
Thank you.
For your elaborative, informative lecture on fertility sparing cancer surgery. जहाँ रहा है वहाँ चाह है, जहाँ चाह है वहाँ रहा है, ये आपने प्रूव कर दिया. When there is a wish, we can get the fertility in the cancer patient.
Yes.
Whenever we heard the cancer, we hope, all our hopes are ended. But you started new hopes. Thank you, sir.
Thank you very much. Thank you. I just wanted to convey that message that we ourselves should accept some change. Then only we'll be able to counsel others. If we ourselves don't believe, we cannot tell anybody else anything. Okay. Thank you.
So one question is, if in the sentinel lymph node mapping, if there is a positive lymph nodes, then?
Yeah, so if there's a positive lymph node, then you have to do the complete lymphadenectomy on that side as well as the other side. So usually in endometrium, sentinel lymph node with well-differentiated adenocarcinoma is very rare. The chance is only 1 to 2%. It's usually when the histopath is already known, it's going to be moderately differentiated or poorly differentiated, then you won't go for fertility preserving approach in the beginning. So in those cases, when sentinel is positive, you remove the uterus, you remove both the side lymphadenectomy, plus depending on the grade, you remove the omentum or the para-aortic lymph nodes also.
Frozen section for all the cases?
I'm lucky to be working in a center where, I myself do a lot of obstetrics, gynac, onco, as well as IVF. So we know how these things are interlinked. So many of the cases we have started using, maybe 2 years back we were not using as much frozen section as we are using today. Just last week we did a case of endometrioma. She was 35, bilateral endometrioma. We just thought ki one side, let's do a frozen section for that side cis, and it has turned out to be borderline. So that helps us intra-op itself do certain things which, otherwise we would miss.
Thank you, sir.
Thank you. Thank you.
Remove the adenocarcinoma generally?
Yeah, she was serous papillary adenocarcinoma. Yeah. Done. Thank you.
Okay. Next lectures will be from Dr. Sandesh Kade sir. He is joining soon from the Abu Dhabi. I think Dr. Sandesh sir didn't need any introduction to the Solapur OBGYN Society. From these tier 2 cities to the international consultant for the endometriosis, but to have, he has a tubal recanalizations and the pelvic repair fertility enhancing surgeries. Mm, he has a best video for the uterine artery occlusions difficult hysterectomy cases, and recognized as authority of laparoscopic surgeons and the expert training in his specializations. He is trained over 200 gynecologists across the India. Over to you, sir.
Hello, can you hear me?
Yes, sir. You are here.
My presentation is there on the screen, no?
Your CV is on
Yeah.
the screen.
No, this my presentation.
Yes, yes, yes.
Management of ovarian endometrioma is. Can you see the presentation?
Yes, sir.
Okay, thank you. Good morning, everyone. At the outset, let me thank the Solapur Obstetric Gynec Society for this wonderful opportunity. It's always the pleasure and privilege to be speaking to our hometown. And at the outset, let me also congratulate Virkar sir and his team for these wonderful activities that are happening. Okay, today the topic given to me is something which I am practicing 70% of my practice now is the endometriosis surgeries. And I am here to speak on the preservation of fertility in perspective of ovarian endometriomas. So what has happened is we are calling endometriosis as the 21st century disease because you can see the incidence of endometriosis is very high nowadays. And the reason being the number of ovulations. When a woman has more ovulations, then the chances of having endometriosis are high. And when you create amenorrhea, we can actually prevent the progression of this disease. So nowadays, women are getting married late, less number of children, and less breastfeeding. So overall, the number of cycles is more than any time ever in the history of womanhood. So I think that is one of the reasons why this disease is increasing. And especially, you will see the disease happens between 15 to 50 years. That is when the ovulations are happening. So we have to cater to the needs of their adolescence, their fertility, perimenopausal and postmenopausal lifestyle. Moreover, you will see that there is a diagnostic delay in endometriosis. All over the world, the endometriosis diagnosis takes around 7 to 8 years. And after the diagnosis, there will be some form of treatment. So the actual treatment which the patient gets or it gets initiated is far more than 7 to 8 years. So we have to understand that we should give up identifying or diagnosing endometriosis based on only endometrioma. Majority of the times, the diagnosis of endometriosis happens when a gynecologist sees a endometrioma, but the disease has started far earlier. So actually the culprit is the deep infiltrating and the endometrioma which actually coexist. So very often 70% of the times when you have an endometrioma, the patient would have at least the peritoneal endometriosis or the deep infiltrating endometriosis, uterosacral involvements. So these things have to be considered. It is just not treating the ovarian endometrioma that would give the best results to the patient. So today the objectives of my presentation are to discuss how to decrease the risk of ovarian loss during the surgery, on the ovarian endometriomas. I am going to speak on the new techniques which we have, that is the ablation and the sclerotherapy, which are an alternative to cystectomy, and how to prevent the recurrences of these endometriomas. And then what are the personalized strategies which we follow in our center here, which is a multidisciplinary team center for advanced endometriosis surgeries. So we have to understand that the ovarian endometriomas can affect the ovary and the fertility potential of a woman. And this has to be dealt up to the age of 50 years and beyond to prevent recurrences. And there is a very high risk of ovarian failure due to surgery. So as I know, in most of the centers in India, almost to the tune of 90%, the surgery offered for endometrioma is either drainage of the cyst or cystectomy. And there are very bad effects of this cystectomy on the fertility potential of the patient. And you will come to know when I show you papers which show that the ovary can be damaged significantly because of cystectomy. But why we do cystectomy is because that is the only tool which we have in most of the centers, or we are not exposed to the other treatment options which are available to preserve the fertility potential or the ovarian reserve of these patients. And this is the reason, this is the biggest reason why we have a big rift between the IVF specialists and the laparoscopic surgeons. When I happen to attend the IVF conferences, I keep very silent because I can see they are actually screaming and shouting at the laparoscopic surgeons, saying that these surgeons don't understand the fertility potentials and they do right and left surgeries and then they damage the ovarian reserve. But we have to also tell them that there are three types of endometriosis. One is the peritoneal endometriosis, second is the ovarian endometriosis, that is endometrioma, and third there is a deep infiltrating endometriosis. This peritoneal endometriosis and deep infiltrating endometriosis affect significantly the quality of life of these patients. And not necessarily we are always doing surgery on the ovarian endometrioma. We can dissociate the surgery on ovarian endometrioma and still perform the pain surgery related to the pain on bowel, ureter, uterosacral ligaments, or the sacral roots which cause low backache, leg pain, radiating pain, sciatica like pain. All these can be still treated. The problem we have in a clinic is when a young patient of ovarian endometriosis comes to the clinician asks, like those typical Hindi movies, do you want pregnancy or you want to get relief of your pain? Now this is not what the approach should be. You can treat both at the same time. It's not like ma chahiye ya beta. Okay, so you should be open to all the possible treatment options for a patient of endometriosis. You can give her pain relief by performing surgery on the ovarian deep infiltrating endometriosis, peritoneal endometriosis, sacral root endometriosis, and be very, very conservative on the ovary and preserve her fertility. So you can see it is not only the ovarian endometrioma, the disease can spread to uterosacrals, the bowels, the nerves, all this can get affected. So the impact of ovarian surgery on the ovarian reserve, we have to learn how to optimize. So first thing is, how do we measure the ovarian reserve? So there are like three parameters. One is the morphological parameter, where we will perform the ultrasound, the basic ultrasound which we do in our clinics, where you see the ovarian volume is a good marker, but not the best marker of ovarian reserve, because sometimes some cysts can give fake ovarian good reserve volume of the ovary, and then we can think that she has a very good reserve. It is actually the antral follicular count which is better reserve marker than only the ovarian volume. There are biological markers or biochemical where you can do blood tests and assess the AMH values. So AMH value of 2 to 6 nanogram is a good marker of a good fertility potential of that patient. And FSH levels also can be used to assess if the ovary is still functioning. But when the levels are above 40, then that is what we consider for the perimenopausal and postmenopausal patients. But the range is very high, and so FSH alone cannot really give us a good predictor as compared to AMH. So by and large, the fertility clinics are now mainly using AMH as their biological parameter for ovarian reserve. And obviously the clinical parameters of whether the patient has good reserve is if the pregnancy test comes positive, that means she has a good reserve. Then whether the patient is responsive to the IVF treatment, when you see very good number of follicles, good number of oocytes retrieved, or the embryos, even the quality of eggs, it's not only the reserve that is important, but the quality of eggs is also very important, and the delivery rate. So these are the various parameters how we can see if the patient has good ovarian reserve. Now, when we consider low AMH values, there is a very good paper which shows that even if the AMH is low, do not be scared or do not scare your patients because of low AMH. See, even if the patient has low AMH, you will appreciate that she was still continuing to ovulate and continuing to have her menses. So suddenly now your lab report says AMH is low, does not mean end of the road. This patient was still having good cycles and was ovulating. And that is what has been shown in this paper, where you will see the spontaneous pregnancy rates of these patients is very good, and only problem we face is with the ovulation induction in IVF, where they want to super ovulate. So low AMH is a problem only for IVF people and not for the regular gynecologists who are treating for fertility. Now maybe because of the other causes of endometriosis, the disturbed tubal anatomy or the adhesions, or mainly the severe dysmenorrhea, dyspareunia, where the patient cannot have intercourse, all this could be the possible reasons for her infertility. And so if you do, and there are really very good studies now to show that treating deep infiltrating endometriosis improves the fertility results when you are very, very careful and mindful on the ovary. So we have to understand that all surgeries do not damage the ovary. There are many surgeries which can improve the fertility potential of these patients and conserve or preserve the ovaries. Now sometimes there is a fake high rise of AMH, especially when you have very large ovaries, ovarian endometriomas. Then there could be a fake rise of AMH, or the patient could be PCOS and endometriosis. So that is the reason why her AMH is high. So we have to be very, very careful when you have very good AMH levels as well. We should not directly go in taking, or the decision should be taken very carefully in particular conditions if the patient has PCOS and large endometriomas, where suddenly after your surgery of cystectomy, there could be a drastic drop in the ovarian reserve. So this is a very practical point which you have to understand when you take AMH as your ovarian marker. Now you will see a lot on lots of papers which have shown that cystectomy significantly affects the ovarian reserve, and the patient should be counseled before the surgery that the surgery has a very high risk on the reproductive potentials of the patient. And more importantly, the type of surgery, the type of instruments which you use, or the electrosurgery that you use, very damaging effect will be noted with the bipolar forceps. So there is absolutely no role for bipolar ablation of ovarian endometriomas in today's era of practice. There are few papers which have shown that the ovarian reserve or the ovarian volume decreases by 50%. Till 2004, we had a paper which showed that the ovarian reserve decreased by 50%. And there was another paper where they used 3D ultrasonography to assess is much better. And they found that it was not 50, but it was almost up to 66% volume loss can happen. And this is from the best known surgeons performing the surgeries. So even if you have the best surgeons in the world performing cystectomy, mind you, it is cystectomy, there is a very high chance of the ovarian tissue being lost along with the cystectomy specimen. And so we have to be very, very careful when we perform cystectomy. And particularly more when you have large endometrium. I know it is very easy in the central part of a large endometrioma where it is very, very loose and we can peel it out very nicely, looks very elegant on screen. But remember, whenever the ovarian size is large, there is proportional loss of the ovarian normal cortex of the ovary and very high chances that the patient will lose lots of eggs and follicles in these large cystectomies. So one should stop performing cystectomy in large ovarian endometriomas. So here there are many other papers as well which show there is significant drop in the AMH values. Also, it should be noted that after few months there is a gradual rise as well. So suddenly if a patient post-operatively comes to any center, we should not do the AMH values. We have stopped performing AMH values after surgery because there are a lot of papers to show that it keeps on dropping in 1 month, 3 months, 6 months, and then it starts to gradually rise, although it will never come to the original value, but definitely the difference is not as much as you see if you do AMH immediately after the surgeries. So what are the different surgeries that can be performed? We have around 6 to 8 surgeries that can be performed on the ovarian endometrioma. So it is a big no to bipolar current where you can coagulate and fulgurate the ovary. So there are many other techniques and I would discuss each one of them and how we can use these techniques to preserve the fertility potential of these patients. So why we have this big problem with cystectomy is we have to understand that there are no histological cleavage plane or surgical cleavage plane between the normal cortex and the ovary. So here you can see there are 3 layers. Most of the time the peritoneal endometriosis is there at the uterosacrals or the lateral pelvic wall. The ovary will come and stick to this peritoneal implants, and over time there will be ovulation and bleeding, and then this bleeding peritoneal implants start invaginating into the ovary, and this is the reason most of the cases will have extra ovarian endometrioma. That is, when you perform the surgery for ovarian endometrioma, you will always see the endometrioma breaks, and it has to be broken because the endometrioma is extra ovarian. Unless you break and drain, you will not go to the ovary. So I see a lot of youngsters are trying to conserve and not break the endometrioma, and finally it ruptures because it is always and most of the time extra ovarian. So you have the extra ovarian side, that is the cyst wall. Between the cyst wall and the ovarian cortex, there is a layer of fibrosis. And we have to take advantage of this fibrosis layer and the ovarian cyst wall and perform surgeries which would damage only the cyst wall or up to the fibrotic area. And it should not reach the cortex area. So ablation on the outer surface or the ovarian cyst wall side is a good technique to perform the surgeries and still conserve or preserve the potential of the patient by not damaging the cortex. So we have ablation techniques like CO2 lasers, or you have plasma energy which can be used to fulgurate the cyst wall, or the sclerotherapy, which is again coming back and showing promising results in many of these studies. So we have plasma laser energy, which can actually, you can plan the depth of energy that can penetrate, and you can very well coagulate only the superficial area, that is the cyst wall. And maximum it can reach up to the fibrosis, but it will never damage the cortex of the ovary. So let us go through literature and see how plasma therapy ablation works against cystectomy. And it shows excellent results. There is a multi-center comparative study, and most of these centers, when they contributed their patients, they could see that the probability of pregnancy is almost equal in both cystectomy and ablation. So it's a very good opportunity for all of us to bring this instrument into in our armamentarium and perform the ablation techniques rather than performing cystectomy. So you have almost comparable results between ablation and cystectomy. So if we can compare the ablation versus the cystectomy versus the drainage. So in this case, there were 363 patients and 56% had ablation, 33 did cystectomy, and 10% of the patients underwent only the endometrioma drainage. And you could still see the plasma ablation and the cystectomy have very good results of pregnancy comparatively, whereas the drainage only had also good results but were far less than compared to ablation and cystectomy. So drainage, simple drainage could also be an option when the patient is immediately going to go for IVF. So otherwise, only simple drainage, the chances of recurrences are higher. And why we used to perform cystectomy for so many years is only because cystectomy, the recurrence rate was lesser as compared to the other techniques. So if you just follow by recurrence, then very often we would end up doing more damage to the patient than helping her actually, because we are scared of the recurrence. And these recurrences are not so common and not so immediate. So we have to be very careful when you do the surgeries or select what weapon are you going to use against that ovarian endometriomas. Another important thing we have to understand is a lot of times we misinterpret. See, now the ESHRE guideline which says clinicians can consider performing cystectomy rather than CO2 laser. We just read this line and then we say ESHRE has also prevented or stopped us from performing other techniques and asked us to do cystectomy. Well, ESHRE was speaking about only the recurrence rate, not the fertility preservation of that patient. So fertility preservation is different, and performing cystectomy alone or just being scared of the recurrence is a different issue. So we have to select what is good for the patient, what gives good results, as well as preserves her fertility. Because not necessarily the patient will conceive in next 6 months, 8 months, or in the first 2 or 3 cycles only. So we have to preserve the fertility. Now let us compare the ovarian cystectomy versus laser vaporization. And there are good randomized control trials for this. And the best one was in 2011 by Francisco Carmona, where he showed comparable pregnancy rates between these two techniques. And the tendency of higher immediate recurrences rate after ablation. So whether we should, that was the only drawback in this technique. But if you compare the fertility preservation, lasers are a good option to preserve the fertility and also go ahead with performing the rest of the surgery on deep infiltrating endometriosis, give a good quality of life as well as preserve her fertility. Another RCT was from Solakadis, where they have shown that CO2 laser limits the decrease in AMH. So the decrease in ovarian preservation or the AMH loss is less when you compare with the CO2 lasers as well. So you can see finally there are better results after the laser options. That is, there is preservation of antral follicular count and AMH values, which shows that the ablation happens only towards the cyst wall or up to the fibrosis and does not damage the cortex of the ovary. So laser CO2 versus the other options for fertility outcomes, you can see cystectomy and laser, the comparative pregnancy rates are almost similar, 72% with cystectomy and 74% with CO2 lasers. So it is a good option again. So friends, it is time for us to just think and not just refute surgeries, because it has been taught to us that endometriosis surgeries are always damaging. It is not so. So we have to think what the patient needs. And now I will show you the sclerotherapy which we perform very routinely nowadays, especially when you have very large ovarian endometriomas, where it has been shown that the cystectomy is more harmful. And large cystic ovarian endometriomas, you cannot perform the CO2 lasers because it is very time consuming and very tedious to perform. So in these cases, we have started performing the sclerotherapy, where we use 95% ethanol alcohol. When we go inside with the laparoscope, we directly go and puncture the cyst, aspirate it. We do not do any adhesiolysis. We do not damage the adhesions at the base of the ovarian cyst, because we do not want the ethanol alcohol to leak into the peritoneal cavity. So go in, aspirate, then fill in. We use the Foley's catheter number 8, fill it with the fluid, and the balloon is inflated. Then you inject the ethanol alcohol and wait for around 10 to 15 minutes. And after that, give a good wash, and then you can start performing the adhesiolysis or the other surgeries that has been planned for, or the patient is having is symptomatic of. So sclerotherapy is a very good technique where the fertility preservation is very, very good, and the chances of recurrences as compared to cystectomy are higher, but not so very common. So it's a very good technique of performing or conserving the ovary. Now I'll go and show you how we make decisions. Here what we have is a multidisciplinary team. All the patients of ovarian endometriosis are discussed in an MDT meeting. There will be urologists, bowel surgeons. There will be, if the patient has the sciatica pain, the neuro surgeons are there, and orthopedicians are there. So when we discuss about ovarian, there are the fertility experts, the infertility specialists. So if we have a patient who has the pregnancy part has been completed, she has no further pregnancy intentions, she has good ovarian reserve, and the cyst is unilateral, less than 5 centimeters. Then in this case, where the reserve is good, unilateral ovary is involved, her pregnancy wish has been completed, she is not intending for further pregnancies, then yes, you can perform a good cystectomy and give her the less chances of recurrence as well. When you have patients where the ovarian reserve is good or low, but you have ovarian endometriomas are more, or the size is less than 5 to 6 centimeters, then in this case we can offer her the ablation techniques. Either you can use CO2 laser, plasma jet, or you can use sclerotherapy, but sclerotherapy is reserved for the larger cysts. It is difficult to perform sclerotherapy in a very small cyst. So in small cyst, plasma energy or CO2 laser is the best way of performing the surgery and preserving fertility. When you have low ovarian reserve and a very large endometrioma, then we have to preserve the fertility. So the best technique is select sclerotherapy. So all our patients will always go for AMH values. Here we always, all endometriosis patients, we do ultrasound and MRI. And after studying the radiologist report in the MDT, this patient is having these lesions. This is the enzyme scoring for this patient. This is the stage of grade of this patient. And then they leave it for the clinicians to decide what is to be done. And then between the infertility specialist and the gynecologist, the operating surgeons, we decide that, okay, this patient would need a sclerotherapy. So we perform the sclerotherapy in these cases. So drainage, like I already told you, when the ovarian reserve is very low, when you have multiple cysts, and IVF is going to be the only choice. Like suppose there is no tubes, the hydrosalpinx has been, the tubes have been removed, or there is an absolute male infertility, where the patient is definitely going to go for IVF, then in these cases only we just drain the cyst and immediately send the patient for IVF. Then they give actually better results than performing any of the ablation also, or performing especially the cystectomy part. And when you have an elderly lady, or when the bilateral cyst age is more than 48 to 50, in these cases, it's always better when she has completed her fertility and the disease is more, then in that case, ovariotomy could also be an option. So friends, I just wanted to tell you that there is not only cystectomy that is performed in laparoscopic surgeries. There are many other options which can be offered to the patient, and then we can do a good surgery for these patients. Now, to speak about pre-operative ovarian preservation or egg storage or egg banking, that's a very good option for young girls, especially when the pregnancy is at not very near, and then they can have a good, very heavy disease. So in these patients, we can actually offer them that they can go for egg preservation and then treatment of or the surgery to be performed. So they are peaceful that okay, I have plenty of eggs in the egg bank and I can perform the surgeries. Even if the surgery is a bit radical, I am not scared because I have the option of egg freezing that is available. So how to prevent the recurrence? It has been shown that a simple oral contraceptive pill, when you use it after the surgery, then the recurrences are very, very low. What we see in our clinical practice is most of the times we give cyclical therapy because it is a cultural problem, or traditionally the patient or herself is asking that she feels uncomfortable without menses for many months. So that's why they give cyclical. But if you see this paper here, you will see the top line, the black line which you see, that is the continuous oral contraceptive pill which is used. And you will appreciate that the recurrence is very, very low or very delayed. And in comparison, if you see a patient using cyclical pill, then the recurrence is bit early, and if there is no use of any medication, it is still faster, and the size of the recurrence, the endometrioma, is also bigger. If you see the second chart, you will see the size of the endometrioma is bigger if you don't use anything cyclical, and if you use continuous pills, that is the best thing or the cheapest method which can be used. So finally, ovarian endometrioma cystectomy is a potential harmful effect on the volume and function, but it should be carefully selected in cases of repeated surgeries or bilateral ovarian endometriomas, or when there are large cysts. So you should be very careful in selecting your patients and selecting the weapon for that particular patient. Ablations using laser or plasma or alcohol, there is a lack of deep necrosis, so it spares the underlying ovarian parenchyma, and the ovarian reserve is preserved, and the ovarian volume also decrease. Might be actually there will be no loss of the ovarian volume when you have the ablation techniques. And despite these observations, the superiority of ablative techniques over cystectomy in pregnancy rate should be proved. Yeah, we understand, but at present, the current literature shows us that it is almost comparative. And consider fertility preservation in young girls, especially before performing the radical surgery, or if there is no option but to do some surgery on the ovary. So, and we can minimize the recurrences by using continuous oral contraceptive pills. So thank you very much for this wonderful opportunity. If there are any questions, I would like to answer them. I would be very happy to answer them now.
To prevent the recurrence, how long we should continue the pill, OC pill?
You have to just continue it depending on her fertility expectations, or if, like, see, this disease is till 50. So till 50, you have to continue the treatment for these patients.
Okay, sir.
हेलो हाय सर, रोहन हियर सर. आपको मिलने के लिए सोलापुर आया, बट आप अभी लग रहा है दुबई का ही टिकट निकालना पड़ेगा आपको मिलने. सर, आई जस्ट वांटेड टू आस्क, इन दिस sclerotherapy, once you put Foley's, and I'm sure the wash is given through the Foley's only. after the
Correct.
sclerosant is removed. Then while you're performing the rest of the surgery, is that Foley is removed or it's kept in place and then the rest surgery is complete and then removed at the end?
No, no, no. We remove the Foley's. Then you can imagine the Foley's bulb when it is inflated and it is pulled. There's a small area of ovary which will not get ablated. I mean, because of the sclerotherapy, the bulb of the Foley's.
Right.
So that area we excise and we take it for biopsy as well. And then we open widely the cyst because thereafter we can suspend the ovary with a T-lift or the proline suture. So no need to keep the Foley's because the Foley's has been inserted through a trocar, okay, and I would waste a trocar during my surgery. So Foley's has to be removed.
Sir, and if by chance the sclerosant happens to spill outside, what are the
Yes.
things that you have noted or how much does it leak or any other post-operative complications noted in these cases? Maybe.
No, if you see while you are injecting, you have to be slow and gentle, and you keep a watch whether there is any leak from the surface. If there is, then this procedure cannot be performed. Okay, if there is a leak. So that's why when we do sclerotherapy, if the patient is posted for sclerotherapy, we just do not go and touch anything. We just go and drain it. Because if you try to do any adhesiolysis, there is a chance that the punctum of the ovary can get disturbed and there could be a leak. If you have some leak, immediately put in a lot of normal saline, give a good wash and aspirate. Nothing to be really scared. Only don't forget to keep the sclerosant alcohol there and forget it inside the ovary itself. So give a good wash, drain it properly, wash it thoroughly, and that is enough for this.
Okay. Thank you, sir.
And this is just the ethanol alcohol which we are using. It's not very immediately corrosive. We have seen it dropping some areas, but it is not like some acid.
Dr. Sandesh, thank you very much. Excellent information. I just
Thank you.
wanted to know whether this sclerotherapy can, how exactly it works, and what happens to the AMH levels if this patient is of infertility. Like, do you do in infertile patients or those who are not willing for it?
No, these are for infertility patients only.
Okay.
Actually, our large ovarian endometriomas where the fertility is to be preserved.
Okay, and
So-
then how does it work?
This is the sclerosant, ethanol alcohol, like how you have for the vascular sclerosants. If you see the for grade 1, grade 2 piles, they don't do perform surgeries. They inject the sclerosant agents. The same way, the ovary after the cyst has been aspirated, we put this ethanol alcohol. Now, when the ethanol alcohol has been put into it gets exposed to the cyst wall. I showed you a slide where you will see the ovarian endometrioma wall is there. So it will act on the ovarian endometrioma wall and it will cause the sclerosing of the wall of the endometrioma. So it ablates the wall by the chemical sclerosant.
Okay, then you leave that wall by itself or you take it out?
No, no, no. We don't do cystectomy. We just take the part of the ovarian cyst for histopathology, and rest of the ovary is opened up and given a good wash, and we leave it as it is. You will see the ovarian volume, the ovary which was very, very grossly distended comes back to the normal size actually.
Okay, and then you can induce these patients later on.
Yes, for ovulation induction.
Sounds interesting. Have you done personally this?
Yeah. We are doing it very routinely here. And next time when I come to, I would invite everybody who wants to learn this technique. When I come there for the next visit, I will put it in our group. You can come. This is a very, very simple technique to perform, and everybody of us should learn this technique.
Thank you, Sandesh.
Thank you, sir, for this enlightening lecture. That is we should think about this. We should twicely think about this cystectomy, and we should think beyond this cystectomy for the ablation and sclerotherapy. Thank you, sir.
Thank you. Thank you so much.
Thank you, Chairperson and the speakers. It was indeed a very informative session. I request the Chairperson to felicitate our speakers. I request Dr. Archana Shah to come forward. I request Dr. Rohan to please come forward for felicitation. I request Dr. Vaman sir to come forward. I request Dr. Virkar sir to please felicitate our chairperson, Dr. Chandrakant and Dr. Lalita. Thank you. We now move on to our inauguration of this CME. I invite our guest, Dr. Kalyan Baramde sir, Dr. Vaman Ghodke, Dr. Rohan Krishna Kumar, to please come on the dais. I also request Dr. Archana and Dr. Pratibha to come on the dais. I request President SOGS Dr. Virkar sir, Secretary Dr. Meena, and Treasurer Dr. Praveen to take their seats on the dais. The lamp lighting ceremony is not only an act of illumination, but also a representation of the triumph of knowledge over ignorance. It is a symbolic reminder that education enlightens and empowers us to achieve great heights. I invite all the dignitaries on the dais to come forward for the lamp lighting and symbolically mark the inauguration of the CME. Thank you. I request our President SOGS, Dr. Virkar sir, to say a few words.
Good afternoon, everyone. Thanks, SOGS member, for coming on this Sunday morning, and thanks all the faculties which are here. As you know, we have selected this topic, fertility enhancing surgeries and approaches. So the fertility enhancing surgeries or restorative surgeries are a unique standalone entity in our practice and requires comprehensive assessment and careful approach while performing. A surgical subspecialty requiring a lot of patience and skill on the surgeon's side. A very meticulous approach to prevent further adhesions formation while doing surgery. As well as we all are aware the recent advances in endoscopic surgery have revolutionized our field of gynecological surgery drastically and easily contribute in a better prognostic and restorative rates among infertility patients than ever before. Thank you so much.
Thank you all the dignitaries. Now we are moving to our next session.
Now immediately we move on the second session. For the chairpersons, I invite Dr. Sudeep Sambharam and Dr. Vijay Pawar. Dr. Vijay Pawar actually needs no introduction, but still a formality. He is a consultant at SIMS Fertility, Associate Professor of OBGYN, VMGMC Solapur, and a unit head. Ex-Clinical Associate, Regenesis Center for ART, Endoscopy and Fetal Medicine. Fellowship in ART and Minimal Access Surgeries. Dr. Sudeep Sambharam, he's UG from VMMC, PG from Mysore. He's consultant at Sambharam's Women Clinic, Solapur. Assistant Professor in OBGYN, ARMCH, Ashwini Medical College. Delivered high quality education and training to students. Member and Board of Directors in Markandeya Rugnalaya. Over to you, chairpersons, to start the session.
Good afternoon, everyone, and I thank you the SOGS for giving me the opportunity for chairing this session. And today our next talk is on endometriosis and enigma. Management of endometriosis by Dr. Pratibha Ballava. Madam has done her MD and MBBS and MD from KEM Mumbai, and has an fellowship in infertility in late Dr. Mandakini IVF Center in 2009, and laparoscopic training under Dr. Hafiz Rahman, and training in high-risk obstetrics and and as an assistant professor at SOGS Hospital in Trivandrum. She's also working, she's the director and consultant at SS Baldava Neuroscience and Women's Care Hospital, Solapur. She is a lecturer at Solapur Markandeya Rugnalaya since 2014, and she has been holding many. She has been a treasurer at SOGS, honorary secretary, life member of IMA, and member of FOXY since 2009.
Thank you so much, Sambharam sir, for those kind words. After the dynamic lecture by Dr. Sandesh Kadi sir on surgical management of endometriosis, I would be just giving a glimpse of medical management of endometriosis. Endometriosis, as we all know, is the presence of normal endometrial mucosa abnormally implanted in locations other than the uterine cavity. So endometriosis is not located just only in the ovary, but it can also be present on the uterosical ligaments, the fallopian tubes, and rare sites like the ureters, the kidneys, and the bowel. Nowadays, we see a lot of cases of deep infiltrating endometriosis. 5 to 10% of women of this reproductive age group have severe pain and infertility because of this endometriosis. So as I just mentioned, the common sites are the ovaries, the anterior and the posterior cul-de-sac, the uterosacral ligaments, and the broad ligaments. Apart from that, rare sites like the ureter, appendix, peritoneum, and the bowel. So what are the risk factors? We know continuous exposure to estrogen causes abnormal implantation of these endometriotic spots and their proliferation, giving rise to this ectopic endometrium, giving rise to endometriosis. So it is basically a phenomenon of increased estrogen, decreased progesterone, and increase in the inflammatory agents like prostaglandins, which is leading to endometriosis. There are various pathogenesis and etiologies. I will not be going into the detail of this, but it is most women have retrograde menstruation into the peritoneal cavity, but endometriosis occurs only in 5 to 10%. Why is it so? It is because the anti-inflammatory features in some of the patients are so strong that even if there is retrograde implantation, they all do not develop endometriosis. Only 5 to 10% develop endometriosis. So, as I just mentioned, it is the epigenetic changes in some people which causes increase in estrogen formation, increase in prostaglandin production, and decrease in progesterone or progesterone resistance that leads to endometriotic implants, causing endometriosis and its symptoms in the form of pain, adhesions, and infertility. So this is again in detail: increased estradiol, increased inflammation, and progesterone resistance, that is a phase of decreased progesterone. So then why are the symptoms of endometriosis felt by the patient? It is because of these endometriotic implants, there is increase in inflammatory agents which sensitize the nerve endings, and that is why these patients feel severe pain. So the sensory nerves from the pelvis go to the brain and inform that it is a painful situation. So then what can be done? So what we are seeing is there is increased inflammatory response, increased angiogenesis, and decreased apoptosis. There are various stages of endometriosis: minimal, mild, moderate, and severe. And this is the latest enzyme classification where we classify endometriosis depending upon its location on peritoneum, ovary, tube, and DIE, that is deep infiltrating endometriosis, and at rare locations, which is classified as F. So then, after we have diagnosed endometriosis because of severe pain, dysmenorrhea, dysuria, dysgeusia, hematuria, or because of infertility, how should we treat it? I will only focus on medical management in 3 forms, that is use of OC pills, which is to decrease the estrogen, or progesterones to increase or decrease the progesterone resistance that is there, that is to increase the progesterone levels in the body, or use of GnRH analogs, which will decrease the estrogen and again increase the progesterone content. So, diagnosis of endometriosis is often delayed, an average loss of around 8.3 years because it is either deep or not seen by diagnosed earlier. Laparoscopic visualization is ideally with confirmatory histology. Laparoscopy remains the cornerstone of accurate diagnosis of endometriosis, and newer techniques like MRI and ultrasound. When this is diagnosed, what is usually done is, if it is severely causing infertility, we would either advise a surgery, or if it is causing severe symptoms like pain, we will advise medical management. So what are the indications for giving medical management? It is to relieve pain, to slow down the growth of endometrial tissue, to improve fertility, and to prevent disease recurrence after surgical clearance is done. So these are the only time when we give medical management. But ideally speaking, the actual treatment for endometriosis is surgery, as Dr. Kade sir just mentioned. If it is in the ovary, as we said, removing or excision of the endometrioma, but if it is fertility preserving, then we do either plasma therapy or sclerotherapy. All those different methods. Actually, the definitive treatment of endometriosis is actually surgical and excision of the endometriotic implants. But only in situations where the patient is either waiting for surgery or is having severe symptoms and wants relief of the symptoms, at that time we go for medical management. Now, what are the factors which influence the choice of our therapy are the woman's age, fertility status, the nature of symptoms, the severity of her symptoms, previous treatments, her priorities and attitudes, the cost and the side profile, the risk of treatment, other fertility factors, and intended duration of treatment, also the best available evidence. So we have to see what are we treating and why are we treating. Mostly we treat to improve natural fertility, enhance the chances of success at ART, pain relief as an alternative to surgery, pain relief while awaiting surgery, adjunct to surgery, prophylaxis against disease recurrence, or to prevent symptom recurrence. According to the ESHRE guidelines, pain can be relieved by either using NSAIDs, that is, we have different analgesics, or by giving hormone treatment, or the definitive treatment, as I said, is already surgery. So different analgesics are NSAIDs or acetaminophen, or we can give continuous OC pills without a break. The word without a break is important because only when we give continuous OC pills are we causing atrophy of those endometriotic implants, and hence is the pathology treated. Or we can give GnRH analogs in the form of leuprolide depot or progesterones like Dynogest 2 mg daily. These are the again various options for treatment of endometriosis. So how do they act? GnRH analogs or leuprolide depot, if we give, it acts at the hypothalamic level and causes anovulation and therefore decreases the estrogen. Progestins or Dynogest, if we give 2 mg 1 OD or 1 daily, it will again cause decrease or anovulation and will have direct effect on the endometriotic implants and will cause their atrophy. Basically, we are aiming at decreasing the estrogen level, decreasing the progesterone resistance by providing progesterone into the system and to cause atrophy of those endometriotic implants. So OC pills in endometriosis nowadays, there is a newer OC pill which is a combination of Dynogest with ethinyl estradiol. Advantage of this using this Dynogest with ethinyl estradiol is it basically prevents relapses, reduces symptoms, eliminates the need for repeat surgery and extends the time between surgery. It has to be tailored depending on the patient's age, preference, pain severity, degree of the disease and desire for pregnancy. But remember, it will not be able to eradicate the disease and increase fertility. Medical management is only and only till the time we are waiting for definitive surgery or for pain relief. So this is how it acts. Highly effective binding to progesterone receptor, there will be decrease in GnRH secretion, decrease in endogenous production of estradiol, hypoestrogenic and hyperprogesterogenic environment, and so decedulation and atrophy of the ectopic endometrium. So these are the various mechanisms by which Dynogest and ethinyl estradiol act. Dynogest has an advantage over other progesterones that it is not androgenic like the other progesterones. So Dynogest is being used nowadays in OC combination along with ethinyl estradiol. So this is how progesterones act. It decreases the inflammatory agents, decreases peripheral estrogen, decreases the progression and the symptoms, and causes the atrophy of the endometriotic implants. So it has been seen by review and meta-analysis that Dynogest is the most efficient alternative to treat pelvic pain associated to endometriosis. The dose is 2 mg one daily for a period of at least 3 months. Now we come to leuprolide analogs, GnRH analogs. Example is leuprolide acetate, but it has been seen that if we give leuprolide acetate for a long time, it depletes the calcium and causes osteoporosis. So whenever we are giving a leuprolide depot, we need to associate a daily supplement of calcium along with it. So again, the mechanism by which it acts is initially it may cause an initial flare of the LH and FSH, but later on it causes downregulation of the pituitary receptors and desensitization of pituitary gonadotropins, and thus inhibition of the HPO axis, and finally suppressing LH, FSH and 6 steroids within 2 to 4 weeks. So this is how GnRH analogs act. It will cause decrease in the uterine contractions, decrease tire mechanism, increase apoptosis, decrease angiogenesis, and therefore decrease cell proliferation. So it has been found that leuprolide acetate depot and hormonal add-back in endometriosis is a better method to take care of endometriosis for pain relief as well as for fertility preservation. So use of leprolide depot in combination with norethindrone acetate 5 mg alone or with norethindrone acetate and conjugated equine estrogen provides effective suppression of the pelvic pain symptoms associated with endometriosis while protecting against bone loss. Thank you so much.
Thank you, ma'am. Thank you for the elaborate talk on medical management of endometriosis. Any questions from the audience?
So I think there are any more questions for Dr. Pratibha? No questions. So I think she has given a very excellent talk and everybody has understood everything. So now everybody can manage confidently all medical management of endometriosis. So only in the endometriosis what we have to think is what is the patient's complaint, why the patient has come to you, whether it is infertility or it is pain. So if it's the pain, then we have laparoscopic management. So and another important thing is the deep infiltrating endometriosis does not respond to medical line of management. So the newer concepts that are coming is the surgical management for deep infiltrating endometriosis. And we are operating a lot of cases of deep infiltrating endometriosis, and it is giving good results. Patients are conceiving with IUI, and most of my cases of ART are being converted into laparoscopy and they conceive with IUI. So IVF cases पण कमी व्हायला लागलेत because of good surgery in deep infiltrating endometriosis. Now the next speaker is Dr. Kalyan Baramde. I would like to invite him on the dais for his presentation on hysteroscopy in infertility. We all know Dr. Kalyan. He is the famous laparoscopy, infertility, obstetric, entrepreneur, Foxy, Amox, you name the organization and he is there. and a very good friend of us. So he will be presenting on the hysteroscopic.
I'm going to talk on fertility enhancing hysteroscopy. Thank you, Dr. Vijay, for a kind introduction. You were mentioning about your role of laparoscopy. I like to just object it. Those cases with grade 1 and grade 2, ISHRE 2022 guidelines says they will help by IUI. Those patients with DIE, everybody may not be successful with IUI. They might require ART, that is IVF ICSI. That is the one thing which I wanted to add. Good afternoon, everybody. I'm really thankful to SOGS. It is like a homecoming again. And my talk will be fertility enhancing hysteroscopy. Sorry, I'm slightly late because of some morchas going on the highway. Uterine abnormalities like polyps, submucous leiomyoma, intrauterine adhesions, chronic endometriosis, and congenital anomalies have been reported to be around 20 to 47% patients who are undergoing IVF cycles. Endometrial polyp, which accounts for 32% among subfertile women, the implantation failure is around 16% cases, and associated endometriosis in around 46% of the cases. When you talk about one of the disease which is query causing infertility, query causing RPL, that is uterine septum, the prevalence is 1 to 2 per thousand, which may vary to 15 per thousand cases. True prevalence is difficult to ascertain as many are asymptomatic and many of the seniors have done cesarean normal deliveries for this patient with septum, and they have come to know that septum is there inside. So infertility in around 20% of the cases, RPL in around 7.7% of the cases, incidence of early miscarriage in 41% of the cases, and late miscarriage in 12% of the cases. Late abortions and premature deliveries, so late abortion in around 12% cases and premature deliveries in around 7% of the cases. The most of the time, whenever there is a malpresentation, fetal growth restriction, placental abruption, or related to perinatal mortality, then you can suspect septum. The other disease which we are going to talk is Asherman syndrome. The prevalence of Asherman syndrome in infertile patients around 4.6% of the cases. Infertility occurs in around 50% of the cases in Asherman syndrome. Early pregnancy loss in 25 to 40% cases. Preterm deliveries in 23 to 30 cases, and placenta accreta in 13% of the cases. Even ectopic pregnancy is noted in around 12% of the cases. So what we are going to talk today is fertility enhancing hysteroscopy. We are going to touch septal resection, polyps removal, foreign bodies, submucous myomas, cannulation, and few other cases like RPOCs. So uterine pathology, everybody knows that a variety of benign intrauterine pathologies are common. Two of the most common are myomas, that is called fibroids, or polyps. So this first case is around 29-year-old lady coming to the OPD with pain during menstruation, increased bleeding pattern with primary infertility for 3 years, history of regular menstruation, no complaints other than altered bleeding pattern, and normal PV finding with normal day 2 hormones, UHG showing intrauterine solitary lesions of 1.5 centimeter, and this is the sonography picture. So many times we are worried whether to go for a hysteroscopic surgery or not. But as this patient is a case of infertility, we have to go for a hysteroscopic evaluation. Though transvaginal ultrasound sensitivity is 19 to 96%, specificity is 53 to 100% of the patient. And if color Doppler is showing feeding vessel, then you have to go for a case of hysteroscopic polyp removal. So these are the guidelines which are AHL, again same TVS, which is going to diagnose as a level B diagnosis, and if you add color Doppler, then it is going to help for diagnosis of endometrial polyp. This is a simple case of endometrial polyp, which I am going to show hysteroscopically how to remove a polyp. Anytime you find a polyp or you are suspecting a polyp, first put an office hysteroscope or even 2.9 millimeter hysteroscope under anesthesia. For youngsters or PG students, first you have to do a survey of the intrauterine cavity. That is very important. Many of the time, even in big conferences, there are complications which have occurred because of non-visualization of both ostia. So first, do a survey, see to it that you see both ostia. Then only you diagnose a case that whether it's a fibroid, polyp, intrauterine adhesion, whatever, until in a case of Asherman syndrome where you may not be able to find ostia. So once you do that, you have to know whether these are the polyps or fibroids. If these are the simple polyps, use a scissors and cut the base of the polyps, and with the help of grasping forceps, you can remove these polyps. In this case, there are 3 polyps, small polyps, which are been removed. And this is a very simple, straightforward case which can be done by anybody in an office hysteroscopy setup, because these are simple polypoid polyps and which are been easily removed by the hysteroscopic grasper forceps. Mind you, if there is a blood vessel or associated fibroid polyp, then you might have to use an energy source for these patients. For the infertile patient with polyp, surgical removal is recommended to allow natural conception or assisted reproductive technology a greater opportunity to be successful. This is level A evidence of Journal of Minimally Invasive Gynecology, and lack of association between size of polyp and fertility outcome goes against a mechanical effect. It is speculated that fertilization and endometrial receptivity may be altered by increased glycodelin production, which happens in this patient with polyp, which is not there in the patient who have no polyps. Also, presence of HOXA10 and HOXA11 gene expression, which is established by molecular markers of endometrial receptivity, and thus it causes impaired endometrial receptivity. So those patients with diagnosed polyp with infertility, you have to remove it. So what is the technique of removing a polyp? You can use a cold scissors, electrosurgical devices, either monopolar, bipolar, lasers, or even morcellation. This is a new tool in the market which is called morcellation, and it is a mechanical morcellation. The biggest advantage which I find in my practice is it is used with a normal saline. There is no use of any of the current in this, and these are the mechanical morcellators, and which has a reciprocatory movement, and thus you have to go to the base or at the top or surface of the polyp, and it is going to eat out the whole of the polyp, and that is how you can do a polypectomy. Are there any advantages than using a scissors or even using a electrocauterization? Yes, there are advantages, because so many times in IVF cycles on day 2 or day 3 you have already started stimulation and you find there is a small polyp which is there and you want to do an embryo transfer in the same cycle. These are the patients where you can do a morcellation in the same cycle, and this patient can be put for the embryo transfer in the same cycle. Now this another patient for IVF which has 3 polyps, and this is a case of recurrent implantation failure. In this patient, you are not going to cause any mechanical injury to the endometrium, so it is these hysteroscopic morcellators are very good tool whenever you want to use for cases of infertility or those patients with IVF or previous repeated failures. These are simple, it is eating out. Even it is said that the learning curve is so less that even in 1 or 2 days you can learn this procedure, and it has been studied in many medical colleges where PGs were given first hysteroscopic morcellator and then they were given scissors and other electrosurgical devices for this. You can see there is a minimal injury to the endometrium, and that's how these polyps can be removed. So whenever you are doing a polypectomy or even fibroid removal, morcellator procedure has biggest advantages that it is safe, it is a mechanical design which eliminates the risk of energy discharge into scarring, and reduces the risk of air or gas embolism. Localized treatment reduces endometrial damage, which is going to be helpful for having an implantation in the future pregnancy. It is effective, targeted pathology is removed under continuous visualization. Efficient because continuous cutting and tissue removal means only single insertion is required. If there are big polyps or big fibroid, you might have to remove it because it is going to cause hindrance so many times. And it is clear because continuous hysteroscopic outflow and suction helps maintain clear operative field, and no tissue is floating into the uterine cavity disturbing, and all the tissue can be sent for histopathology because it is available in your suction bottle. So if you are going for a next cycle of IUI IVF, it is the best tool. No energy source use, no damage to endometrium, and intrauterine adhesion formation tendency is less. So hysteroscopy polypectomy remains the gold standard for treatment, and there doesn't appear to be differences in the clinical outcome with different hysteroscopic polypectomy techniques. Polypectomy is going to help for spontaneous pregnancy and those patients who are going for ART in the future cycles. Uterine cavity is healed by 2 months postoperatively. There is insufficient evidence to advocate specific length of time before women should conceive. So this is a management algorithm. Diagnosis of endometrial polyp, symptomatic polyps needs to have hysteroscopic removal. Those are symptomatic. You have to see whether it's a postmenopausal patient. Then again you need to remove this polyp. In premenopausal, if polyp size is less, then you can consider observation, and next cycle you can remove if size is increasing. So these are certain evidences why you need to remove the polyps whenever case of infertility, and hysteroscopic removal of polyp prior to IUI increases the pregnancy rate. So now we move to a second case of hysteroscopy, that is a submucosal fibroid. This lady came to the OPD with history of secondary infertility, and this USG is showing submucous fibroid of 3 into 2 centimeters. So how we are going to decide which is good route for doing a hysteroscopic myomectomy or laparoscopic myomectomy? Depends on size of myoma, and then depending on the size you are going to use monopolar or resectoscope or bipolar resectoscope. So many times those fibroids which are bigger or type 3, these are the cases where you might have to use hystero as well as lapro approach. And how you are going to decide is decided by the FIGO classification. Submucosal, that is 0, is completely pedunculated, 1 is less than 50% intramural, and 2 is more than 50% intramural. These can be very well tackled by hysteroscopic approach. All others might require laparoscopic approach. This is a very new innovative concept called as Lasmer classification. It is divided into 3 groups, 1, 2, and 3. How we are going to decide which patients have success of doing a hysteroscopic myomectomy, and this is penetration, size, base, lateral wall, third of involved, and then you get a grading system, and that's how those which is 0 to 4, it is completely hysteroscopic myomectomy is possible. Those with score of 5 to 6, complex hysteroscopic myomectomy, that means those who are well versed with hysteroscopy, those who are seniors can do in one setting. These are the patients where you might have to counsel the patient for second setting of doing a hysteroscopy, because these are the complex cases. And those where scoring system is more than 6, that is 7 to 9, always go for a laparoscopic myomectomy. So anytime you get a patient, you do a good 3D scan, and on that you are going to decide whether this patient requires a hysteroscopic myomectomy. The success of doing a transcervical resection of myoma can be diagnosed only on the basis of ultrasound itself. So these myomas cause, sometimes gives a clue regarding the underlying submucous myoma on the ultrasound, and submucous fibroid cause abnormal vascularization of the superficial endometrium. Why you have to remove? This is a study done by Donez et al. It has said that it has a good favorable outcome if you remove submucosal fibroid. Also patient is so many times symptomatic and has menorrhagia. So hysteroscopy cannot only diagnose this pathology but also enables the removal in the same setting, that is myomectomy. Submucous fibroids in particular significantly reduce implantation and pregnancy rates. We are talking about HOXA10 and HOXA11 genes, which is expressed in polyps and fibroids, so removal is important. So what is the infertility? Why fibroids cause is depending on their position. It causes decrease in the uterine receptivity, its pressure effect. If it is near the ostia, it can cause blocking the tubal ostia, and there is a localized cytokine production and poor implantation. So this T0, T1, T2 system which we are talking, hole in the endometrial cavity, more than 50% endometrial cavity, and less than 50% and more than 50% endometrial cavity. This is the classification. So before decision making, we have to know the location, number of the myomas, size of myoma, whether the patient is symptomatic or asymptomatic, whether there is distortion of the endometrial cavity on 3D ultrasound or HSG, previous failed IVF cycles, previous pregnancy losses, and available expertise and resources, and other factors affecting fertility has to be understood whenever you are going to post this patient for hysteroscopic myomectomy. Removal improves the fertility, especially for type 0 and type 1, but remains low as compared to the normal uteri. HSG is less specific, TVS is less sensitive but specific than SIS and hysteroscopy. MRI is superior in classification, but we should not advocate MRI for all the patients where you are suspecting sarcoma, LDH levels are more, than only you are going to go for a MRI for the patient. So this is a small hysteroscopic myoma which can be removed only with the help of the scissors also, and this is a new technique where you just remove the base of the base of the myoma, and that's how afterwards you can use a pressure only and not using a current. You can remove any of the small fibroids with either bipolar or saline resectoscopy. Now this is a resection of multiple myomas. Whenever you find that there are multiple myomas, this patient where you can see there are intrauterine adhesions, and once you are remove the adhesions, then with the monopolar current we are removing these hysteroscopic fibroids. Once you are going to know what is the depth of the fibroid, then you have to decide the strokes which you are going to put. The minimal current has to be applied for this patient. Those patients with posterior wall fibroids has to be removed first, lateral wall fibroid second, and those which are at the fundus and anterior wall can be removed later. So resection of the multiple myomas can be done with the help of the bipolar saline resectoscope as well as monopolar saline resectoscope, and these fibroids can be removed. Only thing which while you are doing the surgery has to remember that these fibroids can float in between. So nowadays we are using more of a hysteroscopic morcellator for doing such cases. This is slightly difficult because it is on the anterior wall of the myoma. Morcellation of posterior wall myoma, which is to be done this is supposed to be the simplest procedure which is done because the fibroid is on the posterior wall, and here first we are trying for a hysteroscopic morcellator. Here you can see again those fibroids with posterior wall myoma, those on the lateral walls are very easily removed with the help of this morcellator. Only risk which is there with the morcellator is sometime it can bleed, which because it doesn't have any current, we have to use a bipolar saline resectoscope to cauterize that area, and these small polyps can be removed with the hysteroscopic morcellations. So this is a case of a morcellation of the large myoma, where you can see again we are using a hysteroscopic morcellation for this. Initially we thought this is because it's a thick fibroid, this cannot be removed, but slowly this fibroid can be removed with the morcellation, and you can see the morcellation is going on. Slowly all the tissues are removed, and even it is thought that all the big fibroid, thick fibroids can be removed only with the resectoscope. We can use morcellation for larger myomas, and you can remove these myomas with the hysteroscopic morcellation also. This is a case again with the hysteroscopic morcellation is done where this fibroid is there, and on the top of it is a small polyp. So first polyp is removed. Once polyp is removed, then hysteroscopic morcellation of the fibroid is done in these cases. So it is a good tool for the beginners also. You have to only disadvantage it is a 0 degree, and second disadvantage which I find is if there is a lot of bleeding in these cases, then you have to use a bipolar saline or monopolar current to cauterize that area, and you can see the whole fibroid and polyp can be removed easily with the morcellation. There is a different technique which is called as hysteroscopic dual approach, where if fibroid is more than 3 centimeter, in such cases you can start with the hysteroscopic morcellation. Again we are seeing the cavity, we are seeing both ostia, and in this case you can see first we are trying with the hysteroscopic morcellator. The part which is possible can be removed with the hysteroscopic morcellation, and the remaining part is because this was a thick fibroid, we are removing with the again monopolar current. So that's how you can use a dual approach also, and that is a good tool to have in your basket because hysteroscopic morcellator has least disadvantages. So these are the post-myomectomy adhesions. This case patient has adhesions after the previous removal of the fibroid, and it has been removed very clearly. So wherever there are fibroids which are causing infertility, causing menorrhagia, pressure symptom, these are to be removed by hysteroscopic approach. It can be done with the current or without current like a morcellator. So the next case which is there we are going to discuss is a scanty menstruation with altered color vaginal bleeding followed by amenorrhea, history of DNA done 1 year back for incomplete abortion. Imaging pathology is there is no withdrawal bleeding, so this pathology which is called Asherman syndrome, which is also called intrauterine adhesions, intrauterine syndicate, sclerotic endometrium, endometrium sclerosis. And these patients where the history can be hypomenorrhea or amenorrhea, infertility, recurrent implantation failure, recurrent pregnancy loss. This patient if conceived can have preterm labor, placenta accreta, intrauterine fetal death. So this is a 2D ultrasound which is generally not very reliable diagnostic test, but you can do it with which is going to show you echogenic, irregular, eccentric lines with endometrium or as focal narrowing. This is a patient with a normal triple line we've seen, and there where you can see Asherman with calcification shadows, which is seen. If there is some fluid, then it can be seen very well. So TVS has specificity of 95%, and 3D ultrasound has specificity of 45%, sensitivity of 87%. Should we consider SIS or HSG in the diagnosis or proceed for hysteroscopy to confirm the diagnosis? It is always better if you are done a 3D ultrasound to go for a hysteroscopy directly, but in centers where a hysteroscopy facility is not available, you can do a SIS. Adhesions are specifically seen as bridging bands of tissue that distorts the cavity, and flimsy adhesions are described as thin and undulating membranes which are seen by SIS. These are the simple HSG pictures from our practice where normal HSG is seen. On the left side and right side, you can see intrauterine adhesions. Adhesions are always seen as filling defect, described as homogeneous opacity surrounded by sharp edges and do not change with the positioning of the patients. So many times it is not an artifact, and these are the intrauterine adhesions. This is a hysteroscopy which is a gold standard for all these patients. You can see the mucosal adhesions which are there, and you can see the fibromuscular adhesion. Depending on this, the mucosal adhesions are slightly and frequently pink like the surrounding endometrium and easy to lyse, and fibromuscular adhesions appear as thicker, wide band, and these are difficult to remove. So AAGL recommendation for diagnosis of intrauterine adhesions is hysteroscopy is the most accurate method for diagnosis of intrauterine adhesions and should be the choice wherever available. If hysteroscopy is not available, you can use HSG or SIS. MRI should not be used for diagnosis of intrauterine outside the clinical research setting. So this is the ASRM scoring for intrauterine adhesion, which is seen. Look at the extent of the cavity involved, types of adhesions, menstrual pattern, and depending on that, scoring is devised, and the prognostic classification is stage 1 mild is 1 to 4, stage 2 moderate 5 to 8, and stage 3 severe 9 to 12. So the prognosis is the restoration of the menstruation, which occurs if good surgery is done in 70 to 90% of the cases. Pregnancy rate is around 60 to 90%, and 20 to 40% in severe intrauterine adhesion cases. Term pregnancy in around 40% of the cases. Pregnancy complications like placenta accreta, IUGR, or oligohydramnios are more. The most important is recurrence rate is around 20% of the cases. So what should be the preoperative preparation in the patient? What instrumentation you are going to likely to use? Firstly, you have to go estrogen and progesterone bleeding for the patient. If still not bleeding, these are the patients where severe intrauterine adhesions are there. I personally like to put a misoprostol, but many of the seniors who are doing in an office hysteroscopy setup, they don't put any misoprostol or any cervical ripening agent. They just go into with the office hysteroscopy. The advantage of doing an office hysteroscopy is that those intrauterine adhesions are fibrous band, and once you start removing it, it is very simple. The time you enter into the muscle layer, then the patient is going to have pain. So that's how office hysteroscopy setup is good, and scissors are the best instrument to be used. What is assisted or guided hysteroscopic adhesolysis? So many centers advocate putting a laparoscope from above and doing a hysteroscopic adhesolysis, but the recent analysis which is done is showing that there is no definitive advantage until you come to know that you are perforated. Otherwise, there is no use of you doing a laparoscopy while you are doing a Sherman's adhesolysis. Though the assisted or other guided hysteroscopic advantage of ultrasound while you are doing in a hysteroscopy setup, where if good ultrasound is being shown from above, then you can know where you are going, where is the ostia, and how you are close to the fundus, and that is how some centers are using for this. So direct visualization of the uterine cavity at hysteroscopy in conjunction with tool for adhesolysis is the treatment of choice of intrauterine adhesions. In the presence of extensive or dense adhesion, treatment should be performed by expert hysteroscopists only. There is no evidence that hysteroscopic adhesolysis guided by external imaging technique or laparoscopy prevents uterine perforation or improves clinical outcome. However, such approach is appropriately selected in patients may minimize the consequences if perforation occurs, that is level B evidence. So post-operative treatment like Foley's catheter, pediatric Foley's catheter can be kept for this patient, or Lippes loop without any copper can be used, and nowadays Lippes is not available, so copper T without copper can be used for this patient. So this condition was first described by Heinrich Fisch in 1894. The procedures we are going to discuss, energy sources can be used depending on which cases you are doing, whether the adhesions are very thick or not. A significant improvement in endometrial thickness was observed post-adhesolysis. A high blood flow impedance of spiral artery perhaps impairs growth of the endometrium, making it unsuitable for successful implantation. And these are certain studies which 40% of the cases have good outcomes. So this is a simple case of the Asherman's where these adhesions are there which are being removed only by the hysteroscopy, and those adhesions which are at the fundus can be removed by the use of the hysteroscopic scissors. So this patient was a case of secondary infertility. The adhesions at the internal os can be removed by the hysteroscope itself, and those other adhesions at the fundus are removed by the hysteroscopic scissor. So which instrument to be used for doing adhesiolysis? Always it is better to use the hysteroscopic scissors for these patients, and that is because these patients are so many times infertile, they doesn't have menses, so it is always better to use the scissors. But those where adhesions are very thick, there can be some bleeding, or there are few centers which are using a monopolar hook or bipolar hook for the same also. These patients are kept on high doses of estrogen after doing the adhesiolysis, and that is estradiol, validate 2 milligram TDS for 20 days followed by withdrawal bleeding. That is going to help for regeneration of the endometrium. Pediatric Foley's catheter can be kept for those patients with severe endometrium, severe intrauterine adhesiolysis, which is done in the cases. So this can be done with the setting of the office hysteroscopy whenever there is a pain, or patient has to be very well informed and patient has to be very well counseled. Otherwise, it's always better to do under general anesthesia. So facing problem that is important is recurrence. The recurrence rate is around 20% of the patient, especially for severe adhesions, and post-op use of IUD keeps the raw dissected surfaces separated, and that's how adhesions are less. It is in many of the centers where they're using certain agents like hyaluronic acid to prevent the adhesion formation. That is one technique. Secondly, after 7 to 15 post-operative, so many times even a small catheter can be kept and moved inside the uterine cavity. That is going to decrease the adhesion formation. Or after 3 weeks, you can do a repeat hysteroscopy to do the adhesiolysis for these patients, and such intrauterine balloons can be kept inside the uterine cavity. This is a small video how to put a balloon inside the uterine cavity. That is post-adhesiolysis, and this balloon can be then inflated inside, and then you can come out, and that is going to prevent the intrauterine adhesiolysis in the cases of severe intrauterine adhesions. The use of IUD, stent or catheter, grade 1 evidence. If an IUD is used post-operatively, it should be inert, that is grade C evidence, and no evidence to support or refute the use of post-operative, intraoperative or post-operative antibiotic therapy in the cases of intrauterine adhesions. Semi-solid barriers like hyaluronic acid are helpful. Post-op hormone treatment using estrogen without progesterone may reduce recurrence of intrauterine adhesion, that is grade B evidence. Now important is role of adjuvants to improve vascular flow in the endometrium has not been established. So many centers who are doing advertisement for PRP, stem cell therapy, they are doing under a research staging, and it has not been proven by any of the ethical studies, and it should not be used until it's in a research status. Patient has to be counseled very well about the use of PRP, its advantages, its disadvantages, otherwise you can face medico-legal problem in the future. Recurrence rate is 1 in 3 in the women with mild to moderate intrauterine adhesions. Follow-up assessment of uterine cavity after treatment is recommended, and regardless of the surgical intervention used, reassessment of uterine cavity after 2 to 3 cycles after the surgery is worthwhile in ambulatory method like office hysteroscopy. So, AAGL guidelines for intrauterine synechiae says hysteroscopy guidance is the method of choice with any tool. Laparoscopy may be combined in case of dense and lateral adhesions. Antibiotic, not a routine practice. Foley's catheter, not recommended. Estrogen can be used to prevent recurrence. Hyaluronic acid gel can reduce adhesions, and reassessment of cavity after 2 to 3 cycles is important. So how much to do a adhesiolysis? Now this very important 2 slides which are coming up. This is too much adhesiolysis, the complication. This is a picture of a LSS done by my colleague in Mumbai, where you can see a lot of adhesiolysis was done for this patient, and she was lucky that they had kept this patient for elective LSCS, and that is how this patient picture is after LSCS. Now this is very important video which is in my practice. This patient was operated in some of the workshop, and this patient was done intrauterine adhesiolysis. Once I have tried at my place, then once second time it was tried in another place in a workshop, and you can see this patient came to me at 25 weeks directly because she was living in a rural part of the India, and now I can see there is a lot of hemoperitoneum inside this patient. There was a pregnancy and there was a small amniotic band which was keeping this baby inside. You can see this. This is a uterus with the amniotic band which is there remaining, and that is how MRI and ultrasound was not giving a diagnosis of rupture of the uterus. And this patient has so thin out uterus, and you can see the directly amniotic membrane or amniotic sac which is there inside, and once we have to do a hysterectomy for this patient. So are we justified in doing a lot of adzolysis twice, thrice? So many times there is a good option of surrogacy for this patient, where you have to do a good adzolysis. The part of around 1.5 to 2 centimeter fundus has to be there whenever you are doing any of the adzolysis for the patient of Asherman syndrome. So this is a learning experience for me, that this patient came to me at 25 weeks, and once we opened, there was baby inside the peritoneal cavity. We had to do a hysterectomy for this patient. So another case we are going to discuss, this is a case 4, where a case of septum. Septum causes miscarriage, recurrent pregnancy loss, malpresentation, fetal growth restriction, preterm labor, and also dysmenorrhea in some patient. In general population, the prevalence is 2%, infertile population 3.5%, and those with recurrent miscarriage, the percentage is around 5%. So all women with RPL should be assessed for uterine anomaly, either with the 3D ultrasound or hysteroscopy. There are evidences that hysteroscopic resection of septum improves the pregnancy rate and live birth rate. Incomplete septum removal improves pregnancy, live birth rate, and lowers this. So whatever study says, it is going to be helpful for the patient. The Cochrane review says most studies of metroplasty for separate uterus combine women with recurrent miscarriage and infertility, and no study has been published that randomizes infertile women to treatment versus no treatment. For this reason, controversy exists as to whether infertile women with septum should undergo a surgery of metroplasty or not. So most studies of metroplasty for a septate uterus combine women with recurrent miscarriage. No study has been published which randomizes infertile patient. The diagnosis of septum is 3D ultrasound, sonosulfonography, or MRI. The most important is all gynecologists are now doing TVS 3D ultrasound, so we can diagnose septum better than radiologists, and it is not required to send this patient for HSG for this diagnosis. This picture, which is of ASRM uterine septum fertility sterility of 2018, this picture should be there always in the OPD. I have put this picture as a dictum for diagnosis of the septum. Again, you can see normal arcuate uterus depth is less than 1 centimeter. And septate uterus depth is more than 1.5 centimeter, the angle is less than 90 degree, very important angle. And in case of bicornate uterus, depth of indentation more than 1 centimeter, this angle is more. So wherever depth is more than 1.5 centimeter, angle is less than 90 degree, it is suggestive of septum in cases where you are going to diagnose. And here the important is fundus is single, and in case of bicornate uterus, the fundus is were divided. So does septum affect infertility? Whenever you are talking about the fertility enhancing, there is insufficient evidence that conclude that uterine septum is associated with infertility. Infertility can be result of multiple factors. It is often difficult to determine, only septum can cause this. Does treating a septum improve obstetric outcome? Some limited studies indicate that hysteroscopic septum incision is associated with reduction in subsequent miscarriage rates and improvement in live birth rate in patients with history of recurrent pregnancy loss, but the evidence is again grade C. So some limited studies indicate that hysteroscopic septum incision is associated with improvement in live birth rate, so that is also grade C evidence. So are you going to do it in your clinical practice? Always a patient comes to you, you are going to do, because there are advantages than any of the disadvantages for this patient. So whenever you are doing a septum incision, which is the good instrument, what is the septoplasty, and how will you decide the endpoint? This is a simple case where is a small septum which is removed by the hysteroscopic scissors. You can remove this septum with the scissors, and in one go, when at the end of the surgery, when you can see both ostia in a panoramic view, that is the point which is called as end point of the septum. And these are the patients where you are using different sources, like this is a monopolar current which you are using for doing this is a bipolar saline which has been used for doing a septum resection, or septum incision. Why I am saying this term incision and resection is different, because in septum incision, you are going to do this all procedures, and septum resection, where septum is more of the muscular part, then you are going to cut from both sides and you are going to send it for histopathology, that is called as septum resection, and this is septum incision, this is the end point of the surgery. This is a complete septum. These are the patients where septum is available from the vagina till cervix and inside till the fundus. So these are the patients where first you can either do a hysteroscopic vaginal septum resection, or like this you can do the septum resection, and afterwards you can put a pediatric Foley's balloon catheter from the left side, and from right side you can start doing a septum incision for this patient, where the incision you can see with the saline bipolar we are doing. This is a blind incision which you are taking and you are perforating on the opposite side so that you can enter into the opposite cavity, and on opposite cavity, so that you should not injure anywhere, we have kept a pediatric Foley's catheter. You can see till the point you don't see the pediatric Foley's catheter, you have to be slightly cautious enough, and once you can see the pediatric balloon Foley's catheter, then that is a point where you can remove the catheter and you enter into the opposite cavity, and then you can do the procedure of septum incision on the opposite side as well as till the fundus you can go. This is a very interesting case of the Robert's uterus, where incomplete septum is available and she is menstruating through a small hole. That's why there is no hematocolpus on the opposite side. These are the patients where you can see I am going inside, I can find only one cavity, single ostia, and when I put a laparoscope from above, I can see that on both sides there are cornus, but the septum is not seen. In such cases, you have to blindly perforate either with the scissors or with the saline bipolar resectoscope, and that's how you enter into the opposite cavity, like you can see, and then afterwards the procedure is simple of doing a complete septum resection, or you can see this. Now I have entered into the opposite cavity and I am doing a septum resection or septum incision on this side, and then it can be carried out till the fundus level. So these are the different cases of Robert's uterus can be seen. Lateral metroplasty for unicornate uterus or T-shaped uterus. This is very important for fertility enhancement. Those patients with unicornate uterus, this is important. Or those patients with T-shaped uterus, you can do a lateral metroplasty with fundal metroplasty. So many times those patients, you are getting reports of T-shaped uterus, or on 3D ultrasound, if you find that there is a T-shaped uterus, you can do a lateral metroplasty, that is both walls you can cut 1.5 to 2 centimeter deep, and also you can do a fundal metroplasty in this patient. So the another entity which we want to talk in a fertility enhancement hysteroscopy is the proximal tubal block. HHG shows sensitivity of 53%, HycoC shows 93%, proximal tubal block accounts for 15% cases of tubal factor infertility. It can be sulfingitis, ischemic nodosa, that is SIN, 40%, endometrial corneal polyp 10%, corneal spasm 20%, and other are stromal edema, tubal debris in 30% of the cases. So whenever there is a proximal tubal block, we have options of IVF or tubal surgery. That is depending on the patient's age, patient preferences, associated fertility problems, cost, expertise. Most of the time it is diagnosed to have pulmonary tuberculosis, and those can be treated, and those other cases with proximal tubal block, you can do a hysteroscopic tubal cannulation. If it's a SIN, then tubal resection and anastomosis, which can be done like tuboplasty, which our next panelists are going to discuss. So this is a recommendation of committee opinion, role of tubal surgery in this era. These treatment may improve the chance of pregnancy, so they should be tried like this. A corneal cannulation can be done for any patients where there is a proximal tubal block is there. So anytime a corneal block is there, you have to use these such catheters, and you can go inside and do the cannulation, and these patients have 40 to 60% of the cases will open the tube, and these patients can have a diatesis after this. So the last thing which we want to discuss in the hysteroscopy fertility enhancement is morcellation of the bony spicules. Nowadays, because of the PCPND tag, second trimester abortions are very less. Still, those legitimate second trimester abortions where they are done in a small places, sometimes such bony spicules are lost inside the uterine cavity. Patient goes home and comes with a secondary amenorrhea, secondary infertility, ultrasound showing calcific shadows inside the intra cavity. So firstly, we were doing this with the help of the grasper forceps. Now we are doing with the morcellation of these bony spicules. See, the advantage of doing a morcellation for such bony spicule is that a single small pieces are also going to be get morcellated by doing a morcellation of such bony spicule. Another advantage is that it doesn't, while removal of these scapula or whatever skull bones, they are going to get stuck into the myometrium and they can be remaining there. So that disadvantage is not there with the morcellation technique. So this morcellation can be done, and a single small piece also can be removed by the help of the morcellation. So this is the biggest advantage of morcellation of bony spicules. So hysteroscopic morcellators have advantages. It eliminates the need to remove the fragments with hysteroscope, easier to master the conventional resectoscopy, and preserve the tissue for histopathological advantages. So morcellation, as we have discussed. Now this is a retrospective analysis of outcome of hysteroscopic morcellation and conventional resectoscopy of uterine submucous myoma, a study by an Indian Dr. Vidya Bhatt, in which it has been quoted that hysteroscopic morcellator for removal of intrauterine myomas offers a good alternative to conventional resectoscopy only in terms of reducing operative time, less visual field obstruction, and reduced fluid deficit as compared to resectoscopy, but the surgical outcome remains similar in both techniques. So the cost of morcellator is too much, is around 20 lakhs, so you can do with the resectoscope, but those who are new, or those who are very senior, where centers have everything, you can go for this investment. So recommendation of ASRM is that hysteroscope is a definitive method for diagnosis and treatment of intrauterine pathology. Costly and invasive method for uterine cavity evaluation. It should be reserved for further evaluation and treatment of abnormalities defined by less invasive methods such as HSG and sonohysterography. Routine hysteroscopy before IVF, the INSIGHT trial. Routine hysteroscopy doesn't improve live birth rate in infertile women with a normal TVS of uterine cavity. Very important. Previously, the role of 3D ultrasound was very less. That is why we were doing pre-IVF hysteroscopy. But now with the smaller polyps can be diagnosed, intrauterine adhesions can be diagnosed with the 3D ultrasound. So women with normal TVS ultrasound of the uterine cavity scheduled for a first IVF treatment should not be used. Women with normal TVS should not be offered routine hysteroscopy. Though I might contradict everybody, because those patients want something new from you because he had 1, 2 or 3 IVF failures. You counsel her for a good 3D ultrasound. You can take an endometrial biopsy, you can do an ERA, and that's how you can come to a conclusion of failure of endo. So take home message, routine hysteroscopy before first IVF not to be done. Intrauterine pathology should be addressed by hysteroscopic diagnosis and treatment. Hysteroscopic surgery increases chance of pregnancy and live birth, spontaneous or after IUI or even after IVF. Vaginoscopic, that is no-touch technique approach, has several advantages. It is safe, cost-effective than conventional surgery. I'm really thankful to Team SOGS for giving me this opportunity. Thank you so much. Any questions?
Yeah. Any questions for Dr. Kalyan? I think sir has already very elaborately explained about the hysteroscopy, and very nice collection of all the cases. So I hope one day I also have such a collection of my own cases.
I have a good collection of hysteroscopy complications also. Maybe in next 6 months I'll come for that lecture. Yeah. Because that is also important to show everybody that hysteroscopy also can have complications, like simple perforation, or even you are entering into the cavity, you are entering and catching the bowel or something like that. These are very important. There can be hemorrhage, which is very routinely seen. I have some 10, 20 good videos about that also, because my hysteroscopy number has gone me on 10,000. That is why I got this collection. Thank you so much. Yeah.
Thank you Kalyan.
Thank you everybody. Thank you so much.
Thank you, chairpersons. You please be there for some time. As now we move on to the interesting topic of today's CME. A debate between tubal recanalization is better than IVF. In this, two debatants are there. For views, Dr. Vaman Godke, and against views, Dr. Pratibha Valdava. Both of them will have 8 minutes each for their presentations, to present their views, and 2 minutes to counteract. And our chairpersons, Dr. Vijay Pawar, will give the judgment remarks afterwards. I invite Dr. Vaman Godke to present his views on 4 views.
Again, in fertility enhancing surgeries and IVF, I am talking against the IVF. So, tuboplasty is better than IVF. Why? Because we surgeons used to tie the hearts together and not the sperm and embryo. We used to tie the heart together. So, in tuboplasty, the thing is patency and potency is again one important thing. We believe in patency, that is medial end patency, lateral end patency, and the complete tubal patency. After patency remains potency, that's their decision. Then indications for tubal reversal. Just to, because of our population and all the things, when we consider to avoid such complications, we used to do tubectomy. And for a fertile patient, so why patient is not becoming pregnant? Because of us. We will reverse our own job, again a team will be formed because there is no problem in fertility. So, basic motto behind the tuboplasty is allow the oocyte and the sperm to meet. So, reversal of sterilization. What are the indications? For the tubal reversal in cases of sterilization, then tubal block, ectopic, salpingitis, then few contraindications are there like age, ovarian reserve, damage or other contraindications. So contraindications, tubal length, effective tubal length if it is less than 3 centimeters, then adhesions, contraindications for pregnancy, severe male factor infertility. So male factor also should be considered while doing tuboplasties. Then tubal anastomosis might be interstitial, isthmo-isthmic, ischemo-ampullary, ampulla-ampulla, ampulla infundibula or cuff embryoplasty. So these are the tubal anastomosis sites, different sites, that is interstitial isthmus, isthmo-isthmus, isthmo-ampullary, ampullary and ampulla-ampullary, and then cuff embryoplasty. So here the isthmo-isthmic or the isthmo-ampullary has a better success rate. So this is ampulla-ampullary and the ampulla infundibula pelvic, this anastomosis. So tubal anastomosis, it is a site specific. When we can do tubal anastomosis for all tubectomized cases except fimbriectomy. So in cases of fimbriectomy, what we can do is cuff embryoplasty, which is not that effective method. So again, depending upon the type of tubectomy, like clip and ring has a good success outcome after reversal. Then the effective tubal length is very important. If it is more than 4 centimeter, then pregnancy rate will be more than 50%. Why it is so? Because our tube is nothing but it is our natural incubator. So tubal length as an incubator, if it is more than 4 centimeter, it will act as an incubator. If you see the nature's rule, ovulation, oocyte, sperm, oocyte, then the fertilization, day 1, day 2, day 3, day 4 and day 5. Till day 5, it will reach into the endometrial cavity and the implantation will start. For that, the effective tubal length is very important. Initially, if you see, before these advanced medias, what are the medias for IVF? TFN, that is tubal fluid media. So, everything occurs in the tube only. So, the prerequisites are surgeon experience, suture material, laparoscopic equipments and plastic surgery, laparoscopically like 3 millimeters in equipments. Tubal anastomosis, suturing technique, one can suture it with single layer or double layer or continuous. It doesn't matter, only patency matters. Then tubal anastomosis with guide wire or without guide wire. The tubal anastomosis techniques depend upon these tubal conditions, then we use of vasopressin or not, then medial and lateral ends are refreshed and then patency is tested for each end and after anastomosis. With vasopressin, vasopressin sometimes can cause peritubal edema and it can confuse with the ostium, this cilia. And here without vasopressin one can do it safely. So it's time to watch few techniques like with guide wire. Here medial end is prepared, guide wire is passed to the lateral end after preparation. You can see the length of fimbria, it is too small. So only fimbria like 5 millimeter fimbria, it is very difficult to suture by judging the cilia. So one can put the guide wire and suture it, and after suturing we can test the tubal patency. Here tubal length is too less, but we can try. So this is the case of previous 3 cesarean sections with adhesions for tuboplasty. So these are the adhesions, you can see the bladder adhesions also, but good tubal ends, medial end and lateral end. So medial end, lateral end, 2 ends with good length. So first thing is medial end is prepared. The next thing is patency for the medial end, it is patent. Before anastomosis one should test it. Then the lateral end patency. After that the anastomosis. Like here you can see the cilia all around. Then first suture is the mesosalpingeal suture where both the ends are brought together, and then the tuboplasty suturing, that is first suture out in and in out at around 6 o'clock suture, because this suture it is very difficult to take afterwards once we tie other sutures. Then after taking sutures at the different places, there is some problem with the video. In tuboplasty, we have to take the sutures meticulously to avoid the kinking. Just take both the ends together, see the alignment, how the alignment is, and maintain that alignment while taking the sutures. So this video is again playing, why I don't know. So you have to bear a little bit with this video. This is the medial end patency after preparing the medial end, then the lateral end. So these are the cilia all around. So after mesosalpingeal suture, we can take both the ends near so that closer, so that the whatever suture we are taking should not be under tension, or sometimes if we miss the thread, then again we have to take the sutures, which is very difficult once we tie the sutures. Then this is the first suture. While suturing, again, see the handling has to be minimum because it has to fulfill the rules or the principles of microsurgery. And suture, here in a single layer I am suturing. That's why I have included the cilias, the lateral end, and closer to the lumen in cases of the medial end. Once you take all 4 sutures at around 6 o'clock first, then
Last 1 minute.
how much?
Last 1 minute.
1 minute, 8 minutes. So I'll skip the surgeries then. So you can see this is the procedure with the vasopressin. This is the lateral end patency, then next is the medial end patency, and we can suture it nicely. In the last video I have demonstrated the suture techniques and time techniques, but because of time, we can see the patency. This is the free spill after tuboplasty, and for all cases we used to do HSG the next cycle. The laparoscopy follows all principles of microsurgery. Laparoscopic tuboplasty is highly successful procedure. Here, these are the cases, our data. Tuboplasty, then ectopic pregnancies complication, again re-tuboplasty, 3 cases, 1 case conceived and delivered. So re-tuboplasty also we can consider. What literature says is, yes, tubal microsurgeries has its definitive role. Then it's a time to say IVF is better or tuboplasty. Now in tuboplasty is better alternative choice than IVF. As far as the things are concerned, like infrastructure for IVF lab and all infrastructure is required. Then availability, of course, availability at embryologist, then experience, IVF consultant and all. No question of availability in tuboplasty. Once we tie the tubes together, they are always available, because unavailability will be the enjoyment for the peoples after that. So once we tie the tube, then experience, nothing is required after tuboplasty, but all the times with IVF. Then cost factor again we have to consider, and recurring cost. And then of course the results also. What IVF does, and couple helps to the IVF consultant to freeze the babies and all, everything the IVF consultant does. Patient, no. But in tuboplasty, couple only does. Laparoscopic consultant, not much. So in IVF cases, IVF consultant will stimulate the ovary, take the egg, pick up, fertilization, and again transfer, everything he will do. And what couple is do? Couple will do nothing. They will be under tension of cost factor and all, and success. And next is anastomosis helps and couple does. Here only surgeon used to tie the tubes, that's it. So regarding the recurrent pregnancy, suppose after IVF, say about it, what next? Next is IVF. Here, after IVF, there is a one light. But after tuboplasty, they can lighten many lamps, no problem. Cost again for IVF is cost. Subsequent pregnancy, again the same cost. I don't know, sir, is giving with free of cost second cycle or what. But for IVF, second cycle, again cost of freezing and all. So subsequent pregnancy is again costlier. So here for tuboplasty, what are the requirements? Basic requirement and cost. Basic requirement is showering of sperm and potency. That is which is again cost effective. It doesn't require any cost. It will happen by its own. It's free of cost. So my friend, tuboplasty is all the time better than IVF. So thank you so much.
Thank you, Vaman sir. Now Pratibha will enlighten regarding the IVF. In 8 minutes, you have to present your views, Pratibha.
Okay, I hope my time starts now. Okay. Very good afternoon to one and all. This is my first slide of my presentation. Sorry, I have not forgotten to start my presentation. This is for you, Dr. Vaman Ghodke, sir, my worthy opponent. Sir, you are in complete dark. I would like to bring some enlightenment to you. It's our choices that show what we truly are, far more than our abilities. So if we choose tuboplasty over IVF, we are doing a big mistake. IVF is definitely better than tubal recanalization. In the next 8 minutes, you will know why. Starting with the right infertility treatment ensures that you are not wasting any time thinking about the different infertility treatments, and you maximize your success for whichever infertility treatment you start. Confusing though it may sound, but choose wisely. Give the first attempt the best shot. Reasons for wanting a baby after tubectomy. Usually, the couple may want a child after tubectomy in the following situations. Marriage crisis, when it's a second marriage or there is a divorce or death of a spouse. Death of any previous child, or previous children have developed some disease genetic or some irrecoverable diseases. So look at the situation when they have come to you for a child after having a tubectomy. Not every couple comes back to you for a child after tubectomy. So, in today's era where LSCS is so common, getting another surgery done like a tuboplasty and then having a high risk of ectopic pregnancy after tuboplasty. So getting operated again for an ectopic surgery. After that, she'll have a child, even if it is successful, she'll have another LSCS. So, and if after that she doesn't want a child, she'll have a tubectomy. So how many surgeries is she going to have? So do you want to put her into a gridiron, sir? Also, this couple is expected to be in a higher age group. Tubectomy usually is done when the patient has completed her family. Nobody at an age of 18 or 20 goes and does a tubectomy. Obviously, they do it when they've completed their family. So, in today's era, at least when they complete a family, they are at least 26, 28. So, maybe when they have come back for a child to you, they will already be 30, 30 plus, or maybe 35 plus. So, at that age, are you going to offer her tuboplasty? So, that is a viable question for me to you. Laparoscopic tuboplasty is, as you said, needs expertise, whereas IVF has a small learning curve. Yes, sir, you said it needs a setup, but once a setup done is for life. So if you have that short learning curve, you learn ovum pickup, you learn embryo transfer, and you have a lab in your hospital, you have to go nowhere. Tubal recanalization, open tubal reversal is a more invasive technique and requires surgical expertise. Laparoscopic tubal reversal has a long learning curve, whereas ovum pickup and embryo transfer technique has a small learning curve, involves painless subcutaneous injections. Tuboplasty will require few days of hospital stay after a surgery. And whereas in ovum pickup and embryo transfer, these are daycare procedures. The patient comes in the morning, goes back in the evening. Post-operative convalescence period is also high or long in tubal recanalization. It's like an open surgery. So post-IVF, patient does not require bed rest. Patient can be working up to 9 months and she can come and deliver. So the advantages are, nowadays even with the advanced triggers, there is the risk of OHS is less. With single embryo transfer, we can have only a single child, and even if there are multiple pregnancies, we have the option of embryo reduction. The risk of ectopic pregnancy, mind you, is many-fold high with tuboplasty compared to IVF. Because we know that when tubal ligation is done, that itself increases the risk of ectopic. So when you want to repair those damaged tubes, it will further increase the risk of ectopic, which is comparatively less with IVF. In fact, IVF ICSI is the treatment of choice for patients with repeated ectopic pregnancies. So And sir, how do you propose to treat a patient who has come to you for a child when they have other infertility issues like increased age more than 35, low ovarian reserve, low serum AMH, patients with poor sperm concentration and motility? So you said potency. But when the patient is not potent, what is the use of doing a tuboplasty when the husband is having a low sperm count, low motility? Then you have to opt for IVF. Female causes of infertility like PCOS, endometriosis, extensive pelvic adhesions, etc. Also, conditions of female reproductive tract like genital tuberculosis, PID, or Mullerian anomalies, tuboplasty will be of very little help. So IVF, ICSI will be more beneficial for such people and should be offered in the first sitting itself. Tubal reversal is only possible if there are undamaged and healthy fallopian tubes, and it is not possible to find healthy tubes in all cases of tubal ligation. You yourself mentioned that fimbrectomy has poor outcomes after tuboplasty. We see so many patients who get tubal ligation done in camps. So where is the good length of tube maintained in tubal camps? Also, most of the times, fimbroplasty is done at peripheral health centers. So how do you think will tuboplasty help in these cases? If the ligation has left behind a very short length of the tube, as you said, at least 4 centimeters of the tube is wanted to give good outcomes. So the success of tubal ligation reversal depends not only on the anatomy but on the functional status of the tube. So just by doing a good anastomosis, your purpose is not served. We have to look at the functional status of the tube, like hydrosalpinx or ischemica nodosa. If it is present, we have to go for IVF. Also, as I previously mentioned, the risk of ectopic pregnancy is 4 to 5 times more with tubal reversal as compared to only 2 times as with IVF. So I would still recommend so that you revise your presentation and come and rethink again before presenting again that tuboplasty should be offered to these patients. So as a woman has more and more ectopics, the chances for a live birth delivery, it should be, with IVF becomes less and less, and IVF should be offered to these patients who have had a previous ectopic. Also the success rate, as I said, tubal surgery, the success rate of having a good anastomosis is 60 to 70%, but the pregnancy success rate is only 25 to 35%. But with IVF, the success rate can be as high as 50 to 65% per cycle. Thus, give your first shot the best shot. Also, after tuboplasty, you said potency works. But there is so much of uncertainty which is associated with that potency. We don't know when the couple will conceive. And if the couple does not conceive, ultimately we have to offer them IVF. Whereas, in IVF, we have control over so many things. With IVF, we have control over enhancing the quality of the oocytes by using the best protocol as per the patient's serum AMH. We have the liberty of seeing the semen parameters and choosing the best sperm at the time of IVF ICSI. We have the liberty of choosing the best embryo for the patient, and we know the results in a finite period of time. Unlike tuboplasty, where we have to wait till infinity, sir. So as with any infertility treatment, they work better the sooner they are done, as growing age reduces the person's fertility. So I will insist that instead of beating around the bush and advising tuboplasty for a patient, it is always better to advise IVF ICSI for these patients and ask them to go for IVF then ultimately IVF has to be sought after wastage of so much of precious time and money and zero benefit of a previous tuboplasty. So if IVF is opted for, also after tuboplasty, suppose if the patient conceives and they just wanted one child, now what about the contraception henceforth? So they have to again go for a tubectomy or close the tubes. But in IVF, after they have had one child and they do not want any further child, the tubes are already closed. So they need not go for any other surgery again. So thus I feel
Tuboplasty is finding its way to the grave. Let it rest in peace, sir. Also, the cost comparison. Nowadays, with so many IVF centers coming up, I don't think the cost of IVF is as much as it was before. Today, the cost of IVF is almost comparable to a good laparoscopic tuboplasty. It is due to this reason that some people might prefer to go for an IVF rather than a tubal reversal treatment. In today's era, where IVF treatment is easily accessible at nearby centers at reasonable cost, it is the treatment of choice after tubectomy when a couple wishes for it. Thank you. So see for yourself, make the right choice, and sleep peacefully after having a good baby with IVF. Thank you.
Thank you, Pratibha. Presented very nicely. Dr. Vaman, do you want to say anything?
Not as a fight, but she presented nicely, no doubt. But our basic motto is nature is great and nothing is beyond the nature. She said after tuboplasty, if she conceives, then again she has to go for sterilization and she peacefully forgotten she has to deliver again. So things are going to happen, and tuboplasty has its own role as well as IVF also has its own role. Each coin has two sides. She presented one side of the coin and the another side is tuboplasty. It is still evidences are there. Tuboplasty is better in cases of secondary infertility with good amount of success. So thank you, sir.
Thank you, Dr. Vaman and Dr. Pratibha. I request Dr. Vijay to give his remarks.
Dr. Vaman and Dr. Pratibha both have presented very well. And if you see Dr. Vaman's CV, he has a laparoscopy center and he has then turned into IVF specialist. And I am an IVF specialist, but I also do laparoscopy. And I must say, so basically what we have to remember is that what is the patient's age, the AMH, the antral follicular count, and very important is the age. So if the patient is elderly, we don't have too much time to beat around the bush. So very important factor as far as fertility management is the time to pregnancy. So once the patient comes to you for fertility treatment, in how many months she is pregnant. So if the time to pregnancy, your cutoff in your mind should be around 6 months to 1 year. And if the patient is more than 30 years of age, not more than 6 months. So whatever treatment, when you are planning for that particular patient, you have to see whether laparoscopic tuboplasty is going to work or it is going to be the IVF that is going to work for that particular patient. So no particular answer will be there for generalized treatment. It will be individualized to that particular couple, what are their wishes and according to their financial conditions. IVF is still costly. If Pratibha is offering at very low cost, I will send all my patients over there and get it done, and I can take the money at my center. So I have no problem with that. So I don't think so. IVF is still very expensive, especially in Solapur also, and very difficult. Maybe once the government starts its own IVF center, they have started one in Kama Hospital in Bombay and Nagpur. So once it starts, let's see how things work. But I don't think IVF in near future is going to come down. Thank you so much.
Thank you, Vijay, for your pinpoint and diplomatic remarks. I request Dr. Vijay to felicitate our speakers. Dr. Kalyan, sir.
IVF OD बोलायला पाहिजे.
Light लावायचं. Dr. Pratibha. sir to felicitate Vijay. I call upon all the delegates for a group photograph or the audience who are present here.